Okay. So good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick. This is our first session back in person since 2020. So I ask for your patience if we encounter any technical or streaming issues. Please set your electronic devices to vibrate and don't hold conversations in the committee while testimony is happening. If you need to do that, please just be kind and step outside. As a reminder, there's no food or drink allowed in the gallery. Please be mindful of dirty, putting your trash where it belongs and avoid throwing liquid in the trash because otherwise our staff has to clean the committee room when we're finished. And they work hard enough already. So thank you so much for being considerate. We are going to hear from the bill sponsor and the sponsors panel, followed by an all in-person witness, and then all virtual witnesses. So it's favorable, the way people sign up, favorable with amendment, and then unfavorable, and the same thing for the virtual witnesses. The bill sponsor testimony is not limited in this committee, but please don't take, more than, I usually say 10 minutes, but truly no more than 5 minutes. And while all witnesses have 2 minutes to provide testimony, a timer is displayed on the screen, and a sound will be played once you have, your time has expired. Please adhere to our usual committee rules. This is for our wonderful members who have been working so hard, to one question, not one answer from each panel, because then otherwise we end up here very late. Only one witness will be allowed to respond to the question, so when the member asks you a question, decide who's the best person to answer that question. We're not going to have a back and forward because, again, we'll be here all night. Members and witnesses, please remember that in this committee, like all the other committees, we do the work in subcommittees. So there's going to be an opportunity to engage in further discussion in subcommittee work sessions. And we allow everyone to come forward, whether you're for it or against it, in the subcommittee. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. Today we will hear the bills in the following order. It will be House Bill 1149, House Bill 970, House Bill 1146, House Bill 953, House Bill 570, House Bill 681, House Bill 869, House Bill 863, House Bill 725, 685, 1172, and then the last one, 1135. Keep in mind that this order may actually change depending on, witness availability. And if you notice, I have a few bills today on the, today on the list. And usually I like to go last, but we do have some witnesses that need to be in the Senate, which is why the order is the way it is right now. So first, I would like to call 1149, and the panel please come forward, and that is Maryland Medicaid Waiver, Wait List and Registry Reduction, and the WAY Act. Will you be so kind and come up? And you know what, I was gonna go there, but I'm gonna stay right here not to be disruptive, if that's okay. Of course. And thank you very much. So to the committee, last year we successfully enacted a remarkable and ambitious piece of legislation. And for those of you that were able to vote on it, it really did great things for the disability community. We set aside $40 million to end the wait. That bill required a plan from the Maryland Department of Health to reduce by half the volume of wait lists for 8 waiver programs. Those waiver programs are actually the Community Pathway Waiver, Family Supports Waiver, the Brain Injury Waiver, the Home and Community-Based Option Waiver, the Medical Daycare Service Waiver, the Model Waiver for Medically Fragile Children, and finally the Autism Waiver. The bill was sweeping in its scope and impact on so many families. Maryland Department of Health developed the plan, but families were often unable to find placement due to the workforce shortage. So what does 1149 do? 1149 modifies it a little bit. There are 2 amendments. In the amendments, these are technical changes to the language regarding the placement of how the funding will be utilized. And what it does is the following: it authorizes the Medicaid funding to be used for hiring and retaining providers for these waivers. It gives a little flexibility the way the monies are going to be used. And that's simply all it does. And the rationale is that, these families need to find people to do this work. And we need to have a little flexibility on how we allow them to spend the money. So with that being said, that was fast. Rachel, can you continue?
Of course, Madam Chair, members of the committee. I am Rachel London, the Executive Director of the Maryland Developmental Disabilities Council, and the Chair of the Maryland Developmental Disabilities Coalition. The coalition is 5 statewide organizations that work together to improve the opportunities and outcomes for people with developmental disabilities in Maryland. It is the coalition's testimony that you have in front of you. First, want to thank the chair and the sponsor, and we are here to support with the amendment she spoke about, and give you a little bit of background. So there are over 42,000 Marylanders who receive long-term services and supports through Medicaid. And those are mostly through the Medicaid waivers that Madam Chair talked about. And those waivers provide people with disabilities the support they need and want to live, learn, work, and play alongside Marylanders without disabilities. In fact, 11% of Marylanders have a disability that qualifies them for long-term service and supports. Yet, about 18,000 Marylanders with developmental disabilities are in services in those 3 waivers that were already mentioned. Clearly, they rely on those waivers, as do their families. And there's about 24,000 people with disabilities on the community options waiver wait list, while only 4,000 are currently being served. And those are just some numbers to give you an idea of the breadth of this need. So while this bill really does just move last year's along, it does also amend it to clarify that a portion of that money can be used to expand provider capacity, right? Because we need to make sure there are direct support professionals and providers to be able to serve and support the numerous people who are currently on the wait list. Thank you, Madam Chair.
Thank you for being here.
Madam Chair, members of the committee, my name is Matt Rice. I am the Executive Director of People on the Go of Maryland, Maryland statewide self-advocacy organization ran for and by those with intellectual and/or developmental disabilities, IDD. People on the Go is here in strong support of HB 1149 because we see HB 1149 as a necessary step towards ensuring the future of the people that will be the future of the advocacy movement. Right now, somewhere out there, there is somebody, or perhaps a series of somebodies, who may want to help advance Maryland policy forward, as I've had the privilege to do these last several years, along with my colleagues on the Developmental Disabilities Coalition. We see HB 1149 as a necessary step for ensuring a quality direct support workforce. While we acknowledge the work that the governor and his new administration has done for DSPs, there's still much to be done. We're still in the worst direct support workforce crisis that we have seen in many years. But on a more positive note, HB 1149 is simply the way that you can ensure that people with disabilities have the opportunity to unlock opportunity, improve their lives, and move forward in a way that allows them to make a difference. Thank you for your time.
Thank you, Matt, for your work. We really appreciate it over the years. And Rachel, are there any questions for this panel? I have Delegate Chisholm.
Thank you, Madam Chair, and thank
My
you for the bill.
pleasure.
I just want to make sure I understand it. So right now, if you got a waiver, let's say, I'm just going to pick Bella McCree out of the, so you want to go to Bella McCree, but obviously because you can't get there fast enough. If we pass this bill and we add the money, are they going to go out and actively hire more workforce so that we can fulfill more of these unused positions? Is that the vision for it?
So I think it's twofold, Delegate. Thanks for the question. With 20 million set aside specifically for all of the other waivers other than the autism waiver, certainly a DD provider like Bella McCree, we would hope that as more people with developmental disabilities get off the waiting list, right, because that funding first we want to see go to service and supports, and then a portion of it can be used, just like you said, to build the capacity of those providers. Perhaps it is by hiring more direct support professionals that would allow people who choose to be supported by Bella McCree, they would be able to hire the staff necessary to do that.
Thank you, Delegate, for your question. Any other question for this panel? Delegate Kaiser.
Thank you, Madam Chair. Great bill, of course. My question is for Ms. London. I was looking at the fiscal note in your testimony and about the 7 different waivers. I want to better understand about the autism waiver. How many children are on the waiting list for those services?
Great, thank you for the question. So right now, there are about 6,300 children on the autism spectrum, on the autism waiver registry. We don't know how many of them will be eligible for those services because it's a registry. It's operated a little bit differently than a waiting list. But we do know a couple of things. There are 14,000 students in Maryland diagnosed with autism spectrum disorder. 14,000 diagnosed and have that code on their IEP. So we know that number. It's from MSD. And that on average, when a family puts their child on the registry for the autism waiver, they wait 9 years for any services. And many age out before receiving services, in fact.
Okay, Delegate Shaleka.
Thank you so much. I think this question would be for you, Madam Chair. There's one opposition to this, and it's Maryland Right to Life that says the funds would be used for abortion. I don't read that in the bill. Can you let us know if?
Thank you. No, it's not in the bill. These funds are not to be used for abortion at all. For the disabled, to make their life better, to help them live a full life.
To expand the bill we did last year.
That's correct. And
Thank
the
you.
monies are already there. This is not new money.
Great. Thank you so much.
Thank you for the question. Delegate Woods. Madam Chair. It's okay.
So sorry. Please accept my apologies.
It's okay.
I'm trying to, I don't know who I'm asking. I'm asking
Just
her
ask the
if I'm asking-
question.
I'm trying to understand, am I hearing clearly that people with autism were not included? And if so, why is that?
Go ahead, Rachel.
Thank you for the question. They were in fact included. So last year's bill, and then the legislature passed a dedicated purpose account that included $30 million. And this one clarifies what that $30 million will be used. $10 million of that is specifically set aside for children waiting for services under the autism waiver. But adults, or when they age out of the autism waiver at 21, they would be eligible potentially for the other waivers. So the other 20 million goes to support all of the waivers. So they are still receiving services.
Thank you for the question. Appreciate it. Any other question for this panel? Seeing none, I want to take a minute to thank you for your advocacy and to the disability community for your support. Have a blessed day.
Thank you, Madam Chair.
My pleasure. Good luck in the Senate. So now this ends the bill hearing on 1149, and we're going to go on to 970. And this is what I'm doing. I'm doing the same thing we did yesterday. I am combining two bills, 970 and 1146, which is Delegate Kipke and I. And Delegate Kipke, if you can go ahead And if I may have the following witnesses, and that is actually Tricia Rowdy, Nicole Stallings, Barbara Brookmeyer, Robin Elliott, Thomas Beck, Winfred Booker, and then Dorothy. If you can just pull some shares up, that would be great. So 1146 is Delegate Kipke, Maryland Medical Assistance Program, Adult and Pediatric Dental Services Review of Reimbursement Rates. 970, it's Delegate Pena Melnick, Maryland Medical Assistant Program, Hospitals Dental Services. So I will go ahead and explain why we're combining them, and then Delegate Kipke will give his testimony. And thank you so much to everyone for your flexibility. So we have been actually working for the last 2 months, every Friday afternoon at 5 o'clock. I want to thank everyone, a group of us with the Hospital Association, the dentist, the Medicaid, Tricia, you know, the delegate involved, staff, you name it. We have come together, the Maryland surgery centers as well, to try to address the following problem. Over the past several years, the availability of hospital operating room for acute dental services has decreased to the point that it's almost non-existent. And who are serviced? These are kids that are Medicaid. And to give you some perspective, we have 1.8 million people on Medicaid in the state of Maryland. 700,000 of them are children. So these are children that are poor. They cannot get their mouth taken care of because there's no OR time in these hospitals. It has been a struggle. So I brought them together with staff and all the advocates, and we meet every Friday. We have been able to do some great things. So Tricia, I'm not going to steal your thunder, but when you testified, can you say what you have done? And everybody has given a little bit. You know, sort of like, I don't know if you ever read Amelia Bedelia. I always like to say that, where she made the best pies, but she never knew what the ingredients were, right? So everyone is doing a little bit of this, a little bit of that, but we do not have a stable plan. What the bills in front of you do is to try to look at the program in a holistic way, at the problem in a holistic way, and come up with a solution so we can find a permanent, a permanent plan, a solution for it. Because when we're done here and we don't have those Fridays afternoon meetings, these kids are left in limbo. And they are the poorest in our community, and they deserve to have access to care. So Delegate Kipke and I have worked together with the advocates, with Medicaid and the hospital, to come up with an amendment to try to find a permanent solution, because our kids deserve to get their mouth taken care of, especially very poor children. Delegate Kipke.
Thank you, Madam Chairman, and thank you for all of your work over the past couple of months to advance this cause. This is yet another example of how the issues that we deal with are truly bipartisan and can have a great, serious, meaningful impact, change the lives of people. I mean, part of the reason I vote for bills related to Medicaid and oral health is, you know, you can't get a job, you can't get educated, your health can worsen if you don't have proper oral health care. So I appreciate the partnership with you and everybody else in this effort. One thing that we don't want to do is, obviously, we can't print money, so we can't spend a fortune just throwing money at the problem. We need to be wise in how we approach solving this issue. And so the amendment that strikes both bills, essentially, and becomes the bill, requires that the Maryland Hospital Association do an intent survey of what exists in Maryland currently. And then the Maryland Department of Health, who you may or may not know, actually operates dental clinics and provides dental services in different communities through the local health department. There's a lot of information there. They need to be involved in this as well. And then, of course, the Maryland Healthcare Commission. All of these groups are going to be have agreed to work together to use the data from the hospital to address where there is adequate capacity, look at where there's not enough capacity, and then develop what is essential payment methods to ensure that the access exists in the most cost-effective manner possible. All of this is going to go on throughout the rest of this year. Some of it has already begun, and they'll report back to us before next session. When I first heard this, I thought, great, another study that does nothing. But as somebody who cares deeply about this subject, I can tell you that this has already begun to produce great fruit, great solutions, great reform in this area for oral health and for the Medicaid population, the humans that the system serves. And so I don't, there are people who will share the progress that's been made and continues to be made. And with that, I conclude my testimony. Thank you.
And thank you for the partnership. How about Tricia?
Madam Chair and Delegate, thank you for your comments. We have looked at those amendments, and we have been working with the Hospital Association and other stakeholders and support those amendments. Just to give you, going back to letting you know what we've done through these work group sessions, Medicaid has done a couple of things. One, we are adding a new benefit. It's called silver diamide fluoride, and it is a fluoride treatment that goes on individuals' teeth that have severe decay, and it arrests that decay. So it's a temporary solution. It does work for a certain portion of this population, but it will not be the full solution that's needed in order to make sure that we are serving all Medicaid recipients. In addition, we are increasing our ambulatory surgery center rates so that we can encourage more dentists to use the ambulatory surgery centers. That is part of the discussion that's happening with Madam Chair and the work group members, is to get folks to feel more comfortable with ambulatory surgery centers. Additionally, we are adding money to increase dental rates. We're putting another $20 million into the budget for increasing dental rates. We also put $20 million last year, so again, in total, it'll be $40 million. Additionally, we have we're in the supplemental budget, DBM is working on right now, we are putting $500,000 in that budget to do an outreach marketing campaign. Because obviously a lot of education needs to go to these families. What we've heard from the dentists during the pandemic, obviously underutilization occurred. In addition, which was news to me, and if you think about it, they were at home, not in school, so they had ready.
You can continue.
They had ready access to food, and it wasn't the most appropriate food. And so that contributed to the increase in decay amongst the Medicaid children. And again, lastly, what I will say is why we're agreeing to the study. We have also been asked to comment around our anesthesiology rates. What has come out in these work group sessions is quite a bit of subsidies goes to anesthesiologists that don't go to dentists for similar procedures. And so we need to understand what's happening in the hospitals and what type of money is being provided to anesthesiologists before increasing rates. And then again, just to sum up, again, everything that we're doing here, the hospital ORs needs to be a part of this provider network. It is clear that not everyone can be seen in ambulatory surgery centers. We have children, we have individuals with disabilities that will need sedation into the future, and so they have to be part of our provider networks. And so with that, we support the amendments and we support the work group discussions. Thanks, Madam Chair.
My pleasure. Nicole Stallings.
Thank you. For the record, Nicole Stallings here on behalf of the Maryland Hospital Association. I too want to start by thanking the chair for her leadership on this issue and for convening the stakeholders in these weekly meetings. The issues have been challenging, the conversations have been candid, but the result has been a multi-stakeholder approach that has put already improved processes and enhanced capacity in place across the state to help address the situation. By way of background, about half of Maryland's hospitals provide OR time and staff for these procedures, perform about 6,500 a year. When we were made aware of these wait lists, we were asked to identify which hospitals could take on more capacity and to work through some of the backlog that had built up over the pandemic. And so some of the things that we've done, additional blocks of OR time have been added to accommodate dentists that we worked in partnership with the Dental Association to identify across the state. That work is ongoing. We have hospitals that have doubled their capacity in the last few weeks. We have an additional dentist who was just onboarded in Western Maryland, and that hospital has said we can take any comer if they're willing to come out to Western Maryland. We have another hospital in Baltimore County that doesn't have the equipment or a dental clinic right now, but they are exploring what that would look like to purchase. We have dentists in the queue to be credentialed in Howard County, Baltimore City, and Baltimore County, and we have established a point person at every hospital to monitor these activities. This is progress. It will continue, but as the chair noted, we recognize that we need a sustainable and data-informed plan to maintain this all-hands approach. So we worked with the Health Department and the Healthcare Commission on this amendment to establish a process where we look at data around capacity and also take a critical look at need at a regional level so that we can ensure we are targeting resources where they are most needed to ensure every Marylander has access to the care they need when they need it. Our hospitals are deeply committed to this critically important work. We thank the chair, we thank the sponsor, and we urge a favorable report.
Thank you. Next, please.
Yes, hello. Thank you, Madam Chair and Delegate Kipke, for your leadership on this issue. I'm Dr. Barbara Brookmeyer, the Health Officer for Frederick County, which means I direct the Frederick County Health Department, and I'm representing the Maryland Association of County Health Officers. So I was alerted to this critical access situation when a local dentist in Frederick County in the fall notified me that he had received a 20-day cancellation notice, that he had to cancel his already scheduled patients, about 30, for the subsequent 2 months, and then additional patients scheduled out 5 months. He personally performs almost all of the cases for children enrolled in Medicaid, and that's covering Frederick County, Washington County, Allegheny County, and Carroll County. So while some other dentists do perform some other procedures, not all do for children enrolled in Medicaid. So from conversations with representatives of the Dental Association and anesthesiology, this situation I learned was not unique to Montgomery County, that it's across the state. And while recent concessions have opened up some free time for emergency cases and first come, first served daily basis, the volume previously served, estimated by the Dental Association, will not be served. I'm pleased to hear the progress in the work that's been taking place on Fridays. The system worked well before for the dentists and their patients when they were able to schedule in advance, although the volume of cases demanded months in advance scheduling. So while it worked okay, there still wasn't sufficient access for very timely scheduling. The precipitating factors are complex, and the impact, though, is straightforward. Children and adults with developmental disabilities who are most appropriately treated under general anesthesia have had limited critical access, and it disproportionately impacts those enrolled in Medicaid. Thank you.
Thank you. Dan.
Madam Chair, members of the committee, I'm Dan Doherty. I represent the Maryland State Dental Association. I would like to thank the sponsors of both bills for putting in before you issues that really need to be addressed. Madam Chair, I want to thank you for your leadership, but even more so your energy in trying to move this forward as you have. We have not seen the amendment, so I can't really comment on the specifics of the way the bill will be amended. But we have been, and we will continue to be, work with the Hospital Association and anesthesiologists, et cetera, trying to get care to these children who have extreme decay, infection, and at times even life-threatening conditions. I think that the one part of Delegate Kipke's bill that is very critical to us, and I don't know whether it's in the amendments, but is to review the dental reimbursement rates in Medicaid by comparing it to commercial insurers. As of January 1, 2010, the law went into effect to require comparison of all reimbursement rates under Medicaid with Medicare rates. However, they did not apply to dentistry because Medicare doesn't cover dental care. So for 10 years, there was virtually no increase in reimbursement. We appreciate the money that was allocated last year and this year, but we are playing catch-up for what was basically a drought of 10 years. With that said, we look forward to working on this issue going forward and finding a permanent resolution, and we are fully in support of your efforts, Madam Chair.
Thank you. Thank you so much. We have next Robin Elliott. You can get started. Anyone?
Good afternoon, Madam Chair, members of the committee. Robin Elliott. I'm here today representing the Maryland Dental Action Coalition. I have understood the amendments to really focus on gathering data and do what we would consider a true public health needs and capacity assessment. We fully support this approach to this issue. Each region is going to be a little bit different in terms of both need and facilities, and of course the provider base. And it is absolutely why we have a public health department. It's one of the reasons why you all passed a bill earlier this session about infrastructure for our public health departments so they can do exactly this type of work. Thank you.
Thank you. Next, please.
Good afternoon, Madam Chair and members of the HGO. My name is Dr. Winifred Booker. I paid you all some visits last week, and thank you for that. Thank you for considering my written testimony. What I documented in that was, at the time, I had 26 children waiting to go to the operating room. That list has since expanded to 31. I was scheduled, as you heard earlier, that we have increased our ability to get to the operating room, but there's an infrastructure problem. So I was scheduled to go tomorrow and Thursday and Friday. But now I'm only going on Friday to see 3 of the children versus 5. That is because the hospital doesn't have a dental assistant, and it's too short of a notice for me to get a dental assistant. So this is certainly a multifactorial problem when we consider all of the dynamics, from the lack of oral health education to the food deserts that I document in my written testimony to you. Until we can do better with oral health education, because for dentistry, prevention is the hallmark of what we do. And until we can do better, we have to have operating room access for these children. And because there's no other way to treat many of them when you're 2 and 3 years old, and you have, of 20 teeth, 16 of them diseased, or 14 of them diseased, and some of them abscessed. And so we really appreciate your consideration. This bill is a clear demonstration of what reaching across the aisle should look like. We have our dentists, our physicians, Medicaid, hospital administrators, all working together with our political leadership. This OR Access to Care challenge, we've got to make it right for our children. This bill has the makings of a best practice, not only for Maryland, but for the nation. I ask for your favorable report.
Thank you.
Thank
you for your work. Next, please.
Madam Chair, members of the committee, I'm Dr. Thomas R. Beckett. I'm president of the Maryland State Dental Association Foundation. For those of you not familiar with the foundation, I'll just give you a brief overload. We're the ones that provide the Mission of Mercy care facilities that pre-COVID would do multitudes of care in acute settings. We're now doing what we call mini-moms or mini missions of mercy to help those who are underserved. The big problem that I see here is by combining these bills makes it much simpler in that the OR situation is going down, but the biggest issue is reimbursement rates for those of us in private practice, both in the ORs and in our offices. As Mr. Doherty spoke earlier about the lack of increases in fees for over 10 years, it's a huge problem. I did a little Google search, found a Aetna PPO dental fee list from 2008. That's 15 years ago. The rates under Medicaid that we have in 2013 maybe approximate the rates from 15 years ago in the commercial market. The problem that I find is trying to get my colleagues to sign up to be a provider of Healthy Smiles. And it's because every time they see a patient in Healthy Smiles, they actually lose money. And no one can stay in business, any business, when you lose money. Even if it's a break-even proposition, many of my colleagues would probably say, okay, it's part of the philanthropic thrust that we take as healthcare practitioners. So I'm wholly in support of these bills being combined. I just hope we can look at the reimbursement rates and come up with a solution that is fiscally responsible both to the government and to those who provide the services. I thank you very much, and I wish for a favorable report.
Thank you. So for our colleagues, this is the first panel for Delegate Kipke and I. Are there any questions for any of the witnesses for the first panel? Delegate Shalega.
Thank you, Madam Chair, and I don't know whether this would be for you or perhaps Tricia Roddy, but
Sure.
So coincidentally,
Excuse me, can you ask, Tricia, can you come up, please? And the Hospital Association as well, please. Thank you. Go ahead.
coincidentally, 10 years ago, I worked on this very issue with Ted Sophocles. I was on the Health Subcommittee of Appropriations, and I wish I could tell you that we weren't right, but we had predicted this very thing would happen because, you know, all of the reimbursement rates weren't looked at. So I'm glad you're looking at that, but specifically the anesthesiologist rates. So just for the edification of the committee, I'll be quick, Madam Chair. You know, the anesthesiologists at times will go out and at the ambulatory surgery or at the hospital meet a disabled Medicaid patient who needs sedation just to get out of the car. And so they're working with this patient without really not being their primary care physician. They don't have a full medical background on the patient, and they'll get the patient into the operating room and then, of course, you know, do the much-needed dental work. Obviously, it's critical if it's needing to be done in that setting. And they are the only physician in the room. Yes, the dentists are trained and, you know, wonderful, but they're not a physician in the room. So what can you tell me about, you said reimbursements rates, and you talked about a new benefit and ambulatory surgery rates and dental rates and a marketing campaign and operating room rates, but did you miss the anesthesia rates? Because that was part of the problem 10 years ago.
So at the time, 10 years ago, we increased that one code for dental procedures up to the 100% of Medicare. What we have said is that this year, and it's scheduled for next year, that Medicare is decreasing their rates. We have frozen that rate. In addition, what's coming out, which is news to me in terms of learning about this issue, is that there's a considerable amount of hospital subsidies going to anesthesiologists. In addition, the ambulatory surgery centers quoted last Friday, sometimes giving anesthesiologists around $3,000 a day, in addition to what they're billing Medicaid. And so what we've agreed to in the study is to get at that number so that we can represent the total amount that's going to an anesthesiologist. And again, we've also been asked to compare what dentists provides. It would be reimbursed for sedation compared to anesthesiologists. The dentists are paid less, up to 45 minutes, and then it switches. Again, but it's not the whole picture because dentists aren't getting any subsidies from hospitals or the ambulatory surgery centers for those sedation procedures. So that's why we've agreed to the study and would like to look at it a bit more.
Thank you. Well, I hope it doesn't sound like, have you invited the anesthesia community to the table? Because I think they'll testify, you know, can ask them a few additional questions about reimbursements because, you know, they 10 years ago were more than willing to, you know, help. But at a point that you're losing money, like the dentist said, then, you know, especially with staffing agencies that send anesthesiologists. They're,
Yeah,
you can't lose money forever.
We're happy to bring them on to those discussions, and it will be part of that study that we've talked about. The Healthcare Commission and the Department of Health will work with the ambulatory surgery centers to get those stipends that are going, and then the Hospital Association. By hospital, we're looking at getting the amount of stipends going to anesthesiologists by hospital, and we can include them in those conversations.
Thank you. And they do have quite a bit of information from 10 years ago when it was Chuck Milligan, I think, and you, and Ted Sophocles and I that have worked on this issue. And I'm sorry that we're here and we haven't solved this for the kids that really, really critically need this care. So thank you too for bringing this bill together.
Thank you for your work. You laid the path. Rosenberg and then Hill.
Thank you. And I believe this renewed or heightened interest was sparked by the death of a young man named Dante Driver, if I remember his name
Diamante
correctly.
Driver.
Diamante, sorry. And I recall also that Delegate Oaks was very involved. How would you, and you may have just said it, how would you assess the progress? There's more to be done, and that's why this bill is before us. The progress we've made since then.
So if you remember, after the death of DeMonte Driver, there was a whole work group put together with a comprehensive report. We implemented a portion of those recommendations. We didn't implement all of the rate increases that were recommended in the report. Since then, I think there was in 2015, we gave some for restoration services, and again, 20 million last year and another 20 million. More needs to be done, and we're willing to, evaluate those rates. I think what you heard earlier, we can only be part of the solution. So if hospitals don't allow block scheduling, which you heard from the dentist, the families can't come on a moment's notice. They have to plan, they have to get assistance. In addition, the dentist has to rearrange their schedule. That's the same thing that really essentially kicked off in 2013, was the block scheduling went away for dentists and prompted those discussions. So again, we need the hospitals to be part of the solution. Increasing rates will only do so much. We definitely need the hospitals to open up their OR and provide block scheduling.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank you all for working so hard for solutions. I think I remember the name Dr. Booker had mentioned other infrastructure issues. So, Nicole, the hospitals in just a few months have been able to find some OR time. So can you tell us what you were able to do to find the time that wasn't available, and how you're trying to address the issues of adequate support staff, dental assistants, and the other things, and what other issues you think are there that you don't have solutions for?
Sure. Thank you for that question. I would say we've learned a lot in just a few short weeks. One of the things that has become apparent is hospital leadership were not aware of some of these wait lists. Hospitals do not employ dentists. We don't know about wait lists unless those are made available to us. And so just with this partnership with the Dental Association, working with them to see what are the wait lists by their providers and where are their privileges, and then us making those connections so that there's a heightened awareness. We have seen, okay, let's figure out how we can get you an additional block. And we've looked at utilization. Some dentists use all of their blocks. Some, like University of Maryland Rehab, for example, told me about 59% of the available blocks are being utilized right now. So we have to figure out why that's not working. Is it the days that are available? Is it the times? How can we ensure that we are really maximizing what's been made available, and then also identify what more we need? So enhanced collaboration is certainly part of it. We understand that there have been, I would call these kind of self-inflicted errors, if you will. There were cancellations that were happening for procedures because the hospital did not have access to an anesthesia provider, and they weren't communicating that component to the dentist. So the dentists were feeling like their cases were just being arbitrarily canceled. And so, again, we just need to enhance some of that communication. The staffing constraints are real. for anesthesia in particular, but also the hygienist. I know Dr. Cohn is here in the audience. I've learned that there are examples of dentists who will bring their own hygienist with them to the hospitals for some of these procedures. That is certainly something that we could look like. So I believe we've unearthed a lot of issues that enhanced collaboration and coordination can help with. We certainly need to continue to focus on our workforce shortages. We have also looked at offering up additional slots. Any dentist who wants to be credentialed and privileged at hospitals, but you know very well, Dr. Hill, how long that process takes. It's not quick. And so we've identified individuals at each hospital to try to monitor it and ensure if everything is in place, how quick can this happen? And I've yet to see something happen quicker than 6 weeks, frankly. So that's another area. So I hope what you're hearing is we've really continued to lift the rocks and look to see where we can have improvements. I believe that this, looking at the data and working with the health department and the MHCC will allow us to identify other opportunities as well.
Sure.
Thank you. Do you have any sense, as you're moving forward with these new initiatives and finding time, how long it may take to catch up with all the canceled cases? So let alone the new ones, the people who had cases that were canceled, how long will it take to catch up with them?
That's a great question. I wish I had an answer for you. I think really doing a more targeted approach to understand wait lists. And what do we mean by wait list? If someone is scheduled but it's not until June, that's too long. And so we need to figure out how we can really look at what the wait lists are that we have and assess what we're going to need to be able to work through the backlogs. But I don't have an answer for you right now. Thank you.
Any other questions? And I know this may seem a little odd, given that I am one of the sponsors, and I know my deal is that I will be withdrawing my bill and allow Delegate Kipke to lead it and put the amendment in his bill. I'm trying the honey first, but if we don't find a solution, right, we've been meeting every Friday afternoon at 5 o'clock for the last 2 months, and this was all done without a bill for the committee. You know, all these things they're doing. Once we're done, I don't know they will be able to continue the 5 o'clock meetings, right? I do want progress, and I want these dentists to get block time, because if that list does not move, I will come back and put the bill, original bill, to tie your reimbursement. Okay, so I'm letting you know respectfully that I expect movement, okay? But honey always is good, right? It's sweet. So we're gonna try that first.
Thank you.
As well. So we're gonna go, thank you very, any other questions? Seeing none, thank you. So, and thank you for working on the amendments.
Thank you.
Because you came to the table, and I am very grateful for your work, okay?
Thank you, Madam Chair.
And Tricia, thank you very much, and all the advocates as well. We're now gonna go to the second panel, and that second panel is composed of the following people: Cherie Khan, Andrew Horn, Barbara Brocado, Michael Webb, Det Shattuck, William Chester, and I don't see Andrew Nicholas, but I think, all right, he's not coming, okay. And if you can get started, that would be great.
Thank you, Madam Chair and members of the committee. I'm Shari Cohn. I'm a pediatric dentist in Hunt Valley, Maryland. I'm also a professor part-time at the University of Maryland Dental School. I'm here today representing the Maryland Academy of Pediatric Dentists. I am the public policy advocate for the state of Maryland as a representative to our National Academy. I want to thank you for the opportunity. As a pediatric dentist for over 30 years, I and my colleagues have seen our fair share of early childhood caries or cavities in very young children. As they get older, they miss school and perform poorly on their academics due to discomfort and infection. I left photographs and some charts in your office because pictures speak 1,000 words, so you could see some of my patients with facial swellings. Oral health, as we all know, is the gateway to medical health. Some of these young patients we can treat in the office with nitrous oxide or conscious sedation, but others, due to their young age, inability to cooperate, fear, extensive treatment, or pre-existing medical condition need a hospital to be safely treated. As a sedation examiner for the Maryland State Board of Dental Examiners, I see firsthand, and what I worry about is that because we can't get these kids into the hospital, someone is going to sedate a child in their office that probably should be at the hospital because the child is in pain, and we're going to have a very adverse outcome, if not a death. And I am here to try to prevent that. Because we can't get these kids into the hospital, we need to treat them safely. Dental caries is a disease. It's not elective. The hospitals are cutting time. We sometimes know why. We sometimes don't know why. But who loses out? The kids. We have plenty of Medicaid providers in pediatric dentistry in this state, but very few hospitals throughout the state have the dental equipment, and those that do have limited access. These are our most vulnerable kids. Since the death of Diamante Driver, the General Assembly has been wonderful. We've gotten general anesthesia legislation, et cetera, and we appreciate everything that Delegate Shalega spoke of earlier, and thank you all. My job is representing the Maryland pediatric dentists who need and the children who need treatment in the operating room so that they can have access to hospitals for dental services. I ask that you please think of the children when you vote, and vote in the affirmative for House Bill 970. That's my job. That's your job, too. Thank you.
Thank you. You notice I've been a little bit giving you a couple more seconds because I combined the bills, okay? But let's try to keep up with the time. You're next, please.
Thank you, Madam Chair, and members of the HGO Committee for the opportunity to speak. My name is Andrew Horng. I am here to speak in favor of House Bill 970. I am a pediatric dentist in Rockville, Maryland. I am also a clinical instructor at the University of Maryland School of Dentistry. When I am at the dental school, my role is to train the pediatric dental residents on how to treat patients in a hospital setting. This is an important part of the training of a resident because not all patient treatment can be managed in an office setting. Sometimes this is because of the extent of decay that a child has, sometimes this is because the child is too young to tolerate treatment, and sometimes a patient has special needs that are too difficult to manage without general anesthesia. My clinical instructor position is one that I've held since I finished my residency program in 2005. Outside of the dental school, I spend 20% of my practice time treating patients in a hospital setting. In addition to the University of Maryland Medical Center, I've also had privileges at Adventist Healthcare Shady Grove since 2006 and at Holy Cross Hospital Germantown since 2017. My wife is an anesthesiologist that practices in the area, so I have a good understanding of this issue. I am here to speak as an individual. Prior to December of 2022, I used to average 6 to 8 cases a month at Adventist Healthcare Shady Grove. Since that time, I have only treated a total of 3 patients at Shady Grove. This past week, I had a mom come to my office to ask me whether her daughter, who is in pain, could be seen in the hospital. Sadly, I told her that the soonest I could get an appointment for her is June 2nd. Her child is not healthy enough to be treated anywhere but in a hospital setting. I told her there had been changes at our local hospital that prevented me from scheduling her daughter sooner. Mom looked at me in disbelief. As a healthcare provider who is trained and willing to help her daughter, I didn't know what else to say but apologize. My waiting time for treatment in the OR is the longest it has ever been, and although there are a few surgical centers out there, treatment in a hospital setting remains a vital lifeline for treatment of our most vulnerable patients. I ask that this line of service be restored at our local hospitals. For the reasons that I have mentioned, I ask for a favorable report for House Bill 970. Thank you all.
Thank you.
Madam Chair, members of the committee, Barbara Brocato, here on behalf of the Maryland Society of Anesthesiologists. And before the bills were merged, in support of House Bill 1146, and I particularly want to point you to page 3 of that bill and lines 1 through 9, which address the need to ensure that reimbursement rates paid here are adequate and look at the average commercial rates for all payers. I want to go back to Delegate Rosenberg's point about the death of DeMonte Driver. Then Secretary John Comer's put together a dental action committee with dentists, clinics, others, no anesthesiologists. The recommendations of that committee did result in the dentists' rates being increased to average payments in the southern region of the country, which I think was about 100% increase. They deserved it, they needed it. Medicaid is a terrible payment benchmark for anesthesiologists. At the time of the death, the anesthesiologists were being paid, I think, 87% of Medicaid. That was $17 a unit. The department went up to Medicare, which was at that point $23 a unit. Right now, that's $22 a unit. The anesthesiologists are being paid less now than they were in 2015. We have worked very hard. The anesthesiologists have served these patients and continue to serve these patients. We had a study undertaken by a very reputable consulting firm, Discern, who does studies for the Maryland Healthcare Commission and other state entities to look at this problem. It has been studied. I want to make a point that the hospital subsidies are not just for these cases, they are for uncompensated and undercompensated care for physicians that are not covered by the all-payer system. I'm here to answer any questions that you may have and look forward to making this program work, getting fair payment, and allowing these children to have the access they deserve. Thank you.
Thank you. Next, please.
Thank you, Madam Chair. My name is Bill Chester. I'm a physician anesthesiologist working at Shady Grove with Dr. Horing at times. And I really appreciate the chance to talk to you guys. We were here, unfortunately, quite a while ago, having identified the problem, having gotten a proposed solution, having gotten budget language, and unfortunately, the health department did not deliver on that. And this is the only reason that I can tell you why we're here today. So I don't know why that didn't happen, but I'm going to tell you right now that this problem is easily solved from the anesthesia perspective by putting a rate in which is fair. What's fair? Fair to me means it's a market-based rate in some way, shape, or form. Doesn't matter how, a market-based rate. There's a proposal in, these bills, I support both bills, both of these address that issue. The other thing I can say is that there is an existing rate within the Medicaid structure under which a dentist administers general anesthesia. That rate is acceptable. And that rate's approximately 4 times the anesthesiologist delivered rate for the same service. We put that to the department. There are a couple things I'd like to make clear. One thing, to my knowledge, there is no such thing in this state as a dental anesthesia subsidy provided by a hospital. When there is a subsidy, it's negotiated oftentimes with a third-party negotiator looking at what fair market value for services in that hospital or system is. When that number is agreed to, the hospital and the anesthesia group sign, and that's a subsidy. Has nothing to do with whether or not they're getting paid for anesthesia rates. That just doesn't exist to my knowledge. The other thing I can tell you is block scheduling is a political thing within the hospital, and it's a sort of a give and take between dentists, surgeons, all other providers. So I think that the block scheduling is important, but let's not get distracted. This is really more about, can we afford to provide the services that are being asked? And lastly, I would just say this problem, unfortunately, will not go away unless funds are released to provide fair compensation to the physicians, anesthesiologists, nurse anesthetists doing these cases, and we're very happy to do them. We do every case that comes to the hospital, no matter what they can pay. Thank you very much for your time.
Thank you for everything you do. Appreciate it. Who's next?
Madam Chair, respected delegates, I'm Dr. Michael Webb. I'm Vice President of the Medical Staff at Anne Arundel Medical Center, and I'm Vice President of the anesthesia company who provides anesthesia to Anne Arundel Medical Center, Doctors Hospital, and a multitude of surgery centers in the area. And I apologize for my appearance. I was on call last night, labor and delivery. Gratefully, everybody did well. And I'd like to say that first of all, pediatric dentistry is a very gratifying area to do anesthesia in because these kids do need this care. The care is specialized. It requires special intubating techniques, and the children, we say children, but we forget that not all of them are healthy. Some are disabled, some are developmentally delayed, some have heart, lung, kidney disease, and they need specialized treatment and care. And, but in the end, when they wake up after their dental care, because they didn't have their appendix taken out or something big, they wake up relatively happy, and it's a very gratifying experience. As vice president of the anesthesia company, I have two responsibilities. One is, as a physician, I'm a humanitarian. I look out for the patients individually and the public health. I've been involved with pediatric dentistry for 10 years. Hard to believe. My face may be familiar. I'll continue to work on this issue. But as an employer, I have a responsibility to my office staff, and my employed clinicians to make sure that they have a stable environment and that they receive a regular paycheck. The current reimbursement schedule does not allow us to do that. And I thank you for your time.
Thank you for coming from the hospital here. We really appreciate it.
Madam Chair, members of the committee, Dan Shattuck here, wearing a different hat as the Executive Director of the Maryland Society of Anesthesiologists. We've heard a lot of good testimony today. I just wanted to share that this has been an important issue for the membership of the society going back all the way to 2010. And we've done our due diligence in looking and studying the problem, looking at the problem, trying to become part of the solution. As you've heard from the doctors today, these cases are being done. They don't have the ability to really look into the financial status of the patients that they see in any given day. It's only, at the end of the day where we see where the gaps are. And I'm appreciative of you, Madam Chair, for bringing the group together and having us all at the table to work towards solutions. And we look forward to being part of those discussions. Thank you.
Thank you. Thank you for all your work and for everyone that has been coming on Friday. If I have not thanked you, I thank you. Now we're going to open it up for questions for this panel. First, we're going to start with Delegate Shalega.
Thank you, Madam Chair. Thank you all for being here, and I wish we weren't saying deja vu all over again. So obviously, the cases that are coming before the anesthesiologist are complicated. The dentists are not able to do them safely in their office, and that's why they're ending up in the hospital. So I have two quick questions. One, I was wondering if the cancellation rate was still a problem, because 10 years ago, part of the scheduling problem was the Medicaid patients didn't always show up. And then secondly, I don't know who would best answer that. Somebody else may answer this. The actual rates you were talking about, because we talked about this in detail, Ted Sophocles and Trish Roddy, Chuck Mulligan and I. So I think you said, Barbara, 23 per unit. And what are the dentists getting per unit for sedation?
So I'm going to start it backwards if I can, because, going back to 2010, the anesthesiologist rates were 17. They went to 22. I went to 23. Now they're at 22. Back in 2012 to 15, when we used budget language that was never implemented, the average commercial rates for anesthesiologists for that code were $78 a unit. We were getting 22. Now the average commercial rate for that anesthesia code is $93 a unit. We're getting $22 a unit. The dentists for general anesthesia get $71 a unit. Per unit. So, so the dentists are getting general anesthesia, the $71. The anesthesiologists are getting $22. Their average commercial rate is $93.
Is cancellation still an issue that was part of the problem as well?
It is. It's significantly more amongst this group, but it's significantly less than it was 10 years ago.
Good.
So I think what happened was, when this first started, we went from 700 to 2,000 cases a year at Shady Grove Hospital. And of those 2,000, a significant fraction were no-shows. So I think we were complaining and working with the dentist that, hey, this is a waste of everybody's time, let's fix this. And they responded, and they did do it. Some of it is probably not going to go away. It's higher in these patients than other patients, but it's something I think we're going to have to deal with in any situation.
Thank you.
Better, but not gone.
Thank you. Any other questions for this panel? Seeing none, thank you very much, and thank you for being at the table, okay? I appreciate it. Next, we have two virtual witnesses, and if you will be so kind, can you let them in? And these will be the last two witnesses for these two bills, since we combined them. We have Sydney Chavis from the University of Maryland School of Dentistry and Nora Miller-Smith from the League of Women Voters. Ms. Miller-Smith, will you be so kind and get started?
Yes, good afternoon, Madam Chair, and members of the committee.
It's been a long day, Ms. Miller-Smith. Thank you. Go ahead.
My name is Nora Miller-Smith. I'm speaking on behalf of the League of Women Voters Maryland in the support of House Bill 970, and I'm also speaking as a nurse and a grandmother. The League believes that healthcare is a human right and that all Marylanders need access to affordable, equitable, quality healthcare, including oral healthcare. We need to remove the barriers to obtaining dental care for intellectually and developmentally disabled individuals. Chronic dental pain is torture, and untreated tooth decay can worsen to the point where an infection spreads to the brain. While Diamante Driver didn't have a developmental disability, his inability to access dental care for his decayed tooth ultimately led to his death. Access to dental care saves lives. Dental care for developmentally disabled individuals can't usually be done in a dental chair. They can't tolerate it. You can't just tie a patient down in a dental chair and force them to keep their mouths open and not move for an hour. And if you opt for sedation, then a dental anesthesiologist has to be there. But not every dental office is equipped for this. Not all providers accept Medicaid, and not every patient is stable enough to undergo deep sedation in a setting where emergency care for an unexpected problem is not immediately available. Sometimes the only appropriate setting is in a hospital OR, where anesthesia can be administered and medical backup is available if needed. But unfortunately, per an oral health policy center, financial pressures have forced hospitals to prioritize surgical services based on profitability. Medical surgery procedures are better reimbursed than dental, and displace dental cases from scheduling in many hospitals. My 8-year-old grandson with Down syndrome and autism could never tolerate dental care. Finally, my son got authorization for a dental anesthesiologist to enable the long office procedure to get done with sedation. But not everyone is medically stable enough for this in an office setting. So I hope disabled individuals will be which they are entitled. Thank you so much for letting me speak.
No, thank you for making time to be here with us this afternoon. We're grateful. Are there any questions for Ms. Nora Miller-Smith? Seeing none, thank you for being with us, and I hope you have a great day. The next person is not there? Okay. All right, so the last witness, which would have been Sydney Chavis from the University of Maryland School of Dentistry, is not there. So this actually concludes the bill hearings on House Bill 970 and 1146. So we took care of two. All right. Thank you so much for being with us today. We really appreciate you. All right. Next, we actually have my last bill of the day, and you will be happy for that. It's actually House Bill 953, and it's the Public Health Overdose and Infectious Disease Prevention Services Program. May I ask my panel to come up, please? And I also have the Baltimore City Health Department, someone here from the Baltimore City Health Department? Baltimore Harm Reduction Coalition, Ron Phillips, Susan Sherman, from the Johns Hopkins Bloomberg School of Public Health, Susan Sherman, and Jesse Dunleavy. That is the panel. If you can come up, that would be great. And thank you very much for being with us. I appreciate it. So, good afternoon, committee. Thank you for being so kind and generous with your patience as I present the third and last bill of the day for me. I want to thank you in advance because I know we have quite a few witnesses, and I want to thank the witnesses and the advocates for your work on this issue. So since 2020, Maryland alone has lost nearly 7,500 lives to overdose. The maps you see in front of you are the different jurisdictions. It is a problem in all 24 jurisdictions, 23 counties, and Baltimore City. So why do I have this bill? This bill that is, I'll be honest, very controversial to some. And what I want to ask you today is to have an open mind, to open your heart as to why we need this bill. In Maryland, these maps that you have here, they were actually provided by the Maryland Opioid Operational Command Center. They show that over 1,800 meaningful lives were lost across our state in the first 3 quarters of 2022, of which 80% involve fentanyl. The overdose epidemic is a public health crisis requiring public health solutions, and what you have in front of you is a public health solution. What you have in front of you is a tool in the toolbox. I commend our committee and the Maryland General Assembly for passing laws to address this crisis, from expanding access to naloxone and medication-assisted treatment to authorizing, which was very controversial at the time, syringe services for our community. And yet, people who use drugs continue to die of preventable death. People are dying in back alleys by themselves. They're dying in isolated and shut out in isolated places like bathrooms by themselves, where if someone has seen them, they could have prevented that death. They're shut out from services. You know, increased access to naloxone is great, but it can only serve a life if someone is there to administer it. If someone is not there to administer that drug, it's not going to work. The person is going to die. In my local schools, we're getting 6 overdoses every week in public schools in the bathrooms. It's happening. It is here. That is the reasoning behind this bill. This bill will provide a safe space for people who use drugs to consume the substances they already have and plan to use. Again, they already have them. They plan to use them. In the presence of highly trained staff, they're not gonna give them drugs. They have them. They're gonna bring them. And they can access naloxone and other life-saving interventions. In the event of an overdose, staff can act within seconds. Not a single person has ever died at one of these sites in more than 40 years they have been operating across the world. They have them all over Europe. They have them in Canada. I actually went, and with my wonderful fellow, with Rebecca, we took a train at 7:30 in the morning and we went to New York City. And there are 2 new places in New York City, one in East Harlem and one in Washington Heights. Rebecca actually was able to see both. I went and I actually saw the one in East Harlem. But the minute you enter the location, you see the organization, the staff, very committed. It is clean. The community was involved in the decision making. I went into the room where people brought in their drugs. I witnessed and was present as they took the drugs. I witnessed as staff gave them what they needed that was sterile and clean to make sure that they didn't die. I went upstairs where they have acupuncture, where they have counseling and other resources. This is not just a place where they come and use their drugs. It is a place where they are actually monitored, where they can get help if they need to, where they can get counseling when they're ready. The fact is that people are using and that they're addicted and that they're not going to be ready to stop until they're ready. Whether this is a site where they can come, where they can use, and it can be supervised. There are nearly 200 sites operating in 14 countries. In the U.S., Rhode Island passed similar legislation in 2021. And as I said, New York City began operating the first 2 sanctioned sites in 2021. Our great state of Maryland can join them in doing more to prevent overdose death. House Bill 953 enables communities to access another tool to prevent overdoses and save lives. To be clear, this is not a mandate, this bill. Rather, it would allow community organizations, which is defined in the bill, and approved by the Maryland Department of Health in consultation with the local health departments, to create a pilot overdose and infectious disease prevention program. A pilot program. They will not be in residential areas. It's very clear that it cannot be in residential area. It is very clear that it's only up to 6. It is very clear that it has to be approved by the Department of Health in consultation with the local health department. And to be very clear, these spaces will not provide drugs. We know that drug use is happening, as I said before, so these programs will provide a safe space for people to consume the drugs, so they're surrounded by people, not in isolation. I understand that this approach may not sound intuitive, and I understand that you have initial concerns. However, over 100 research studies have documented the benefits and cost effectiveness of these sites. It actually works. It is proven. And the first sanctioned site was in Canada that opened in 2003 and saw an increased use of detox programs and addiction treatment. They also did not see an increase in first-time drug use. OPS also benefit communities by reducing public drug use, like the location that I went to in New York and saw it. And also syringe litter. All right, people clean, they work together. If we look back a few years, syringe services program also seemed like a bold approach. But we now have 22 of them in Maryland that operate in all regions. Look, we have lost too many Marylanders to overdose. This is a tool in the toolbox. It actually works, and it saves lives. It's really needed, and I hope you open your heart to trying it. It is not a mandate. It is a pilot. It is up to the jurisdictions to do it. It is not in residential areas. Thank you so much for listening. You can go ahead.
Good afternoon, Madam Chair and members of the committee. My name is Dr. Letitia Jarrasa, and I'm the Health Commissioner in Baltimore City, here today representing the Baltimore City Administration to voice our support of House Bill 953. Overdose and infectious disease prevention services programs provide safe spaces for people who use drugs to consume pre-purchased substances in a supervised setting. Staffed by healthcare workers, case managers, and peers, consumers will have access to wraparound services to address their needs. In Baltimore, overdose deaths occur at 3 times the rate of homicides. Baltimore sees nearly 1,000 residents lost to overdose deaths per year. Globally, there are nearly 200 overdose prevention sites in 14 countries. With Europe housing these sites since the 80s, none of these sites have ever had an overdose death. New York City opened the country's first overdose prevention site in 2021, and in its first year of operation, the site reversed more than 600 overdoses. To date, they have had 0 deaths at their location. This is the type of paradigm shift we need here in Maryland and in Baltimore, and this is where we think we have an opportunity to save countless lives. Over 100 peer-reviewed studies have shown the positive impacts of overdose prevention sites. These include having life-saving Narcan readily available for reversals by healthcare professionals, a reduction in HIV and hepatitis C transmission, increased engagement in addiction treatment, access to social, mental health, and medical services, a demonstrated reduction in drug use, increased public safety, reduced syringe litter, and overall cost savings for medical systems and taxpayers. Substance use disorder is a chronic disease that requires comprehensive care and a range of solutions. We would not deprive we would not deprive a diabetic of insulin or an asthmatic of their inhaler. Why would we deprive individuals with substance use disorder of life-saving medication? Why wouldn't we use evidence-based treatments that also reduce infections like HIV and hepatitis C? Overdose and infection prevention sites are a natural extension of harm reduction for our communities and have the potential to save hundreds, if not thousands, of lives here in Maryland. We respectfully urge you to issue a favorable report on House Bill 953. Thank you.
Thank you. Next, please.
Hello, everyone. I am Rajani. I am a director with Baltimore Harm Reduction Coalition and a founder with Bridges. Over the past 6 years, Bridges has been educating and organizing Marylanders in support of overdose prevention sites. When we began this work, honestly, political leaders were not ready to say yes to OPS. I know that because I was right here. Now, we have powerful Maryland institutions on board. Baltimore City's mayor and health commissioner, Montgomery County Department of Health, Johns Hopkins University, various medical associations, community organizations, and places of worship are saying yes on my block to overdose prevention sites. I can confidently say that our state is ready to pilot a handful of overdose prevention sites now. And why can I say that now? New York, all right? On Point, New York City offers supervised overdose prevention services where trained harm reduction workers respond in real time to overdose with doses of Narcan, oxygen, various forms of care. An important element of what makes this work, though, is that On Point NYC offers 3 community outreach teams who conduct syringe pickup, supply and food distribution, and community engagement. They know where they are. They know the people. They provide referrals and follow-up with participants who seek continued care, treatment to manage their drug use, mental health, diabetes, heart conditions, the list goes on. Outside of its uniquely sanctioned overdose prevention site services, On Point NYC offers programming very similar to the 22 syringe service programs that are operating here in Maryland already. For harm reduction workers like the many Bridges members who are here today and watching virtually, we feel a mix of pride that our New York peers are able to provide these life-saving services for their communities and deep frustration that our state is not allowing us to do the same. In Maryland, harm reduction workers are allowed to be there for people before they use and after they use, but not in the moment when they need us most. HB 953 will let us do what we need to do to save lives. Let us do our jobs. We urge HGO to pass this bill. Thank you.
Next, please.
Good afternoon, Madam Chair, committee members. My name is Ronald Phillips. I am the lead recovery coach for the Center of Youth and Families and a proud member of the Bridges Coalition. If you notice, I have no notes because I have it stored in my head, the horrors that I faced when I was an outreach worker distributing Narcan. I have over 50 Narcan reversals in the past 5 years. However, I've lost some people trying to reverse an overdose, and I am traumatized by the look when people lose their lives from the horrible substance of fentanyl. I mean, even though I have over 50 overdose reversals, I probably have even that amount in people who died trying to service them and reverse their overdoses. There are illegal makeshift places where people try to use, but they're not safe. They're sharing needles, and then in turn, that could spread infectious diseases in our city. It is a must that we bring overdose prevention sites to Baltimore City and the great state of Maryland. I'm just a living testimony of why these sites would be a benefit to the city. And I, too, went to New York and saw their overdose prevention sites. And I could just tell you that in my work, I know that the community is ready to have these services brought to Baltimore. But, I mean, people are coming to work in the morning and someone's dead from fentanyl right in their doorway as they're going to work. However, I know that if we had a site like that, the service that I provide to the city, I know that I can direct people that are addicted to fentanyl into one of these services. And in these services, they will have resources to get better and become productive members of society. Thanks for letting me testify among you today.
And I want to thank you on behalf of the committee for sharing your personal story, and we're really glad that you're here. Thank you for your work. You're making a difference. We have Ms. Susan Sherman virtually. Ms. Sherman, will you be so kind and unmute yourself? All right.
I will. Thank you, Madam Chair and members of the committee. My name is Susan Sherman, and I'm a professor at the Johns Hopkins Bloomberg School of Public Health. The views that I express are mine and not those of the university. I've conducted research among people who use drugs in Baltimore and around the world for over 2 decades. I want to echo all of my fabulous panelists and share my enthusiasm for House Bill 953. Overdose prevention sites are a cost-effective, invaluable component of comprehensive evidence-based strategies to reduce the harms associated with drug use and to connect people with necessary mental health, medical, social, and drug treatment services. Sadly, this epidemic, which is so alarming and the numbers are so crazy high, it almost makes you wonder if people are just numb hearing 2,800 last year, 9,000 since we've started talking about this kind of scheme in Maryland. It makes you wonder if we're just numb from hearing these numbers. The drug market continues to evolve. We all know about fentanyl. And now xylazine, a horse and animal tranquilizer, has come on the scene, which causes severe wounds and has a prominent role in fatal overdose deaths. My research has documented the impact of the opioid and overdose epidemics in Baltimore. In a recent study of 350 women who use drugs, 30% reported experiencing an overdose themselves and 35% witnessing a fatal overdose in the past 6 months. Many reported injecting in the equivalent of unsafe consumption sites, vacant buildings, and public spaces such as parks. My group and others have documented overwhelming support for overdose prevention sites among people who use drugs, but there are many other important constituencies to consider. We conducted a study among 150 Baltimore City businesses in areas with high rates of drug use. 85% supported an OPS in the city, and 65% supported one in their neighborhood. This support was largely attributed to their experience with drug use and overdose in and around their businesses. A state authorization is the best legal course of action to establish this evidence-based public health strategy in Maryland. Thank you.
And thank you for the work you do and for being with us today. I'd like to actually call on Jessie.
Hi, my name is Jessie Dunleavy. I appreciate the opportunity to speak, so thank you, Madam Chair and committee members. I am a retired educator, I am an advocate for drug policy reform, and I'm a lifelong Marylander. My son died of an accidental overdose in 2017, a time when there were no services whatsoever to support him. It was either abstinence or die. And he needed health care, we sought it, we failed, and he was incarcerated at one point for a relapse where he was physically abused, where he was consistently hungry, where he couldn't buy food to supplement what he didn't get through the incarceration system. because I'd sent him these green dot money cards, but every time he opened one in the mail, it was stolen from him immediately. He was no match for the brutality of that system, where, by the way, there were drugs. I knew that his death was preventable, and I knew that then. I now know that the majority of them are. There is, on the good side, growing recognition that harm reduction and health care is the better way to go, as opposed to incarceration and shaming. But still we're stuck because our bias for the familiar, steeped in a lifetime of the war on drugs, has us fixated on abstinence and the delusion that prohibition will deliver. Yet overdose deaths continued to skyrocket since 1970. Black market drugs are as prevalent as ever, as are addictions. Increasing analogs of fentanyl and other additives now mixed with stimulants and xylazine predict a new wave of overdose deaths. And we have mass incarceration, and we dump all of our money into these punitive measures. We need to prioritize living. And overdose prevention sites bundle the best of harm reduction in that they provide syringes and health care and a connection to treatment. Why the reluctance to initiate these proven procedures is stigma. So I have one more question. How is it that we're not comfortable with these healthcare provided sites, but we're comfortable with jails and prisons where there is abuse routinely and where there is so much that sets people back in terms of their whole lives? So thank you very much. I hope that you pass this bill.
Okay. This is the first panel for the committee. Are there any questions for this panel? Delegate Bagnall. I'm sorry, Delegate Kaiser.
Thank you, Madam Chair. I lost my question there for a second that I was keeping track of. I just wanted to come back to you. I was listening to both to you and then to the advocates, and I know, and I just wanted to I guess hear it reiterated or ask the question, because some may ask that these type of places would increase use, but I think I heard you say it would reduce overdoses and reduce like reactions to dangerous drugs. Is that what I should be taking from this bill?
And I'm going to allow the witness. Go ahead.
Absolutely. It's a great question. And so what we know, and really just repeating again what Chair Peña-Melnyk had said, there are over 200 of these sites that have been operating around the world, upwards of 30 years. And when we think about it, that's millions of moments, right? Injections or other ways of using in which somebody could have overdosed. And no one has died of an overdose, right? Not a single person. New York City, as the health commissioner said, in 1 year of operating, they reversed 600 overdoses. Their city, the then mayor de Blasio, had, when authorizing this site to operate, the prediction was that they would reverse, I think it was 100 in a year, something like that. They did 100 in 2 months, right? So it's that sort of thing where we think about it enables life. There is no demonstrated, and Dr. Susan Sherman can definitely speak to this, in all the studies and research that exists, there is no data that says that there's an increase in use among any age group. We know in New York City, in fact, one of the sites, speaking to young people, one of the sites actually serves a lot of young people. And they're able to identify the types of drugs that people might be experimenting with at an age where people experiment, and able to get more information and share that information among young people who wouldn't trust any other system to do that, right? These are not people who would necessarily say they are ready for treatment. They are young, they are experimenting, but they're also seeing their friends overdosing and dying. So they come, they test their samples with fentanyl testing strips and otherwise, and they're able to really gather and share and educate each other on what's out there and save each other's lives. And I think that's one thing that's really beautiful. I hope that helps to answer the question.
Thank you. Delegate Taveras, followed by Bagnall.
Okay, thank you. So I'm coming from New York, so I definitely understand what you guys are seeing. One of the things that, and I lived it, so my concern obviously is the pushback that we're going to get on, does this, that in all the reports that we're seeing, I mean, Cato has a real thorough page on this. what we've seen worldwide, yes, it saves lives. But there's no data that shows how many people have recovered and come out of the life. Like, what's the data on that? So if we know we're putting in, let's say, Canada and some of these places are seeing, one site could see 200 people a day, 500 people a day, like in Germany, Canada. How many people from that are coming out of the life? That's the first thing.
There is data on the number of people that seek recovery and treatment that wouldn't have otherwise if they weren't affiliated with people who care about them and provide these services.
And just to follow up a little bit on Ms. Kaiser, can I just inquire? And so the question is, and I just want to make sure I understand what you're saying. I just want to be able to, and you let me know. What you're saying, based on Delegate Kaiser's question, is that because it's a safe space, you'll know better what's moving on in the streets, and you'll be able to inform folks better. So do you have communications with police to be able to manage what's going on in the streets, to clean the streets up from these particular drugs and understanding what's hitting the market?
All right, who's the best person to answer?
In my work, I'm in constant contact with police officers that patrol the Penn North community in West Baltimore. A lot of the younger officers that I encounter are all about finding alternative solutions to just shaking people that are addicted down or this sort of thing. And I just want to speak to the first question about the prevention sites will increase drug use. I beg to differ. It is negative social forces that lead to drug use. So these places are a refuge or a solution to that problem. This will not increase drug use. This will actually serve the addict well in the sense of the resources that will be provided. It's just not a place where you go use. This is a place where you can treat the addict.
Chair, may I add one more thing, please?
No, it's only one person, sorry.
Understood, thank you.
All right, Delegate Bagnall.
Thank you,
Even though
Madam
it's my
Chair.
own bill, I have to follow my own rules.
Totally understand, thank you.
Delegate Bagnall.
Thank you. Thank you to Madam Chair for bringing this bill into the panel for your advocacy. Ms. Dunleavy, we've spoken on multiple occasions. I wanted to take a moment to address the opposition. There is a letter of opposition from the Board of Nurses, and I'm not finding that in the bill, but specifically, is there anything in this bill that compels a provider to provide services in a facility and or shields them from disciplinary action or standards by their employer?
So I'm going to take that. So no. And actually, when I read the Board of Nursing letter, I just thought, with all due respect, it was so silly. Because this is what they say. Nurses may utilize the OPS and OPS staff will not be required to report them to their place of practice in case they left the OPS and went to their place of practice. The board will have to wait until a working impaired complaint was filed before taking action. I mean, that would apply to anyone that comes in, right? I mean, this is not a place to report. The question was asked earlier about whether these sites work with the police. They work, but in a friendly manner, okay? In a very friendly manner. It is extremely unlikely that the presence of an OPS would increase the amount of drug use by nurses. OPS are designed to serve our most marginalized drug users, those who are heavily criminalized for their illicit drug use and do not have another space to use. Nurses have lower rates of illicit drug use than the general population, and by result of their employment have significantly more access to housing and other safe spaces to use drugs, such as alcohol, when they consume at, 6 times the rate of illicit drugs. Should we make bartenders report anyone with a badge to the Board of Nursing? Any other questions? You're done. Any other question for this panel? Delegate Lewis?
Thank you, Madam Chair. I want to thank you for your work, for your commitment and your compassion to saving lives. I think it's so important. And I had the opportunity to visit one of the program sites in New York City, and there was a question I would have asked but I didn't get to. So I noticed that at the New York City site in East Harlem, the site is self-contained, but the activity can spill out onto the public rights of way as customers are coming in to receive treatment or use the laundry facilities to wash their clothes. There's sometimes some socializing and activity on the street. And I just wondered, because in my district, we do have a number of drug treatment facilities, and folks worry about, is this place going to be a good neighbor? Will this organization, will this facility fit into the everyday life of the community? I'd love if you could explain a little bit more the efforts that these places take to be good neighbors, how you can address those conflicts. Thank you.
Thank you so much, Delegate, for coming with us on that trip. It was really actually an amazing experience. Yeah, so one thing to name, I think, regarding many clinics and providers that we have maybe witnessed here in Maryland is that they're not as welcoming, many places. I'm not speaking for all. But many places are more so kind of transactionary, like come in, get what you need, and leave. There's not necessarily a drop-in area, public area to gather, or even just a comfortable area to gather. And so with overdose prevention sites, I think we went on the weather was kind of nicer, right, in December. So you're going to have people wanting to hang out outside a little bit. But they know that it is a comfortable space to be able to come in. And so I think that's a really big part of it. It is not that it's not that the participants are being pushed out. And what we are often witnessing in our state is participants being pushed outside of businesses and organizations. And overdose prevention sites welcome people in, but it's not, okay, you are forced to be in here. It's just live your life, right? And so you can go out, you can smoke outside, and you can come back in. So that's one piece to just kind of make that distinction feel a little clearer. At least it helps me. The other piece is, speaking to the relationship with police, of the sites I've been able to see in Vancouver, Canada, for example, the first site, they have an MOU with the police department, a memorandum of understanding that has become quite a model for a lot of sites around the world, where it's really deep relationship building. And it's understanding that police will kind of have a perimeter in which they're not going to, they're basically going to refer people back inside to the place instead of taking them out or arresting them or taking them to jail. So it's that relationship that also is sort of protecting the area around. The third piece, I'll say, the last piece, is that the organizations that are operating overdose prevention sites in New York are very established in those neighborhoods. In East Harlem and in Washington Heights, those are organizations that have been there for upwards of 30 years. That are highly, highly connected to the neighborhood association, their neighborhoods, the school across the street. They have those relationships, and that then shifts the concept of stigma about people being outside. It's just people who are usually outside. So I hope that helps.
That helps. Thank you. Thank you, Madam Chair.
Thank you. Next, we have Delegate Bagnall, followed by, actually, you already asked your question, is Delegate Shalega, followed by Martinez.
Thank you, Madam Chair. This may be for you. Two quick questions. One would be, is this the same bill that Gavin Newsom vetoed last year and they didn't override it in California? And secondly, it looks like the fiscal note says at least 400 locally, but I saw at a fiscal note when I did a little searching online that these sites cost about $2 million a year to operate.
I was going to start, but then she can't answer, so I'm going to let her go ahead and answer. Go ahead.
Me? Oh. I think that, so Dr. Susan Sherman might be able to speak to the cost-benefit aspect of the costs. I would love to defer to her or you.
Sure,
on that,
go
if
ahead,
that's okay.
Dr. Sherman.
Thank you. So these sites, like any other integrated healthcare facility, do cost if you have all the things people have been referring to, the great sites in New York, which have acupuncture and primary healthcare and provide food. We did a study in Baltimore. They've all the studies that have been done in the US have shown, and in Vancouver, the sites to be cost effective. What we found in Baltimore 5 years ago when we did a cost benefit analysis, that for every dollar spent, there was $4.35 saved in terms of what we're willing to pay for people to get on an ambulance, for people to be taken care of in the hospital for HIV, for a course of hepatitis C treatment. So while, yes, these sites cost $7 million, there's still an excess of a couple $1 million of cost savings. And I'm happy to get you those studies.
And then the other question you asked about
Yes.
I have not seen the California bill, but he did veto a bill that dealt with overdose prevention sites.
And they did not override him. I don't think they had the votes to override him.
In all
so-
honesty, I'm not sure because I don't know the answer, but
Okay.
if they didn't, here we are, Rhode Island passed it, New York is doing it, Philadelphia is doing it, so different people do different things, but it's moving on this side of the country.
And interesting, she said 7 million, NPR said 2 million, so, all right, thank you.
Yeah, well, the fiscal note says that the bill's requirement can be handled with existing budgeted resources, local effect, it can have an impact on the local health departments. It doesn't say what it will cost.
Top paragraph, page 4, that's where it says at least 400,000.
Right, but not 2 million is what I'm saying.
Right, that's why I asked the question.
Yeah.
Because the NPR said 2 million and your witness said 7 million, so.
Yeah, the page 4
It
says.
was a modeling, sorry, it was a modeling exercise. I'm not sure the inputs in the fiscal note or in NPR. I'm talking about something that we did modeling for based on costs of a number of outcomes in Baltimore City several years ago.
And then if you look on page 3, it has additional, this fiscal note's weird, like usually it summarizes it for us in that chart, but in this bill, they've kind of made a little treasure map to figure all the numbers out. So 325,000 is
And
list-
400 on the other, I
Yeah.
read that, but it's not millions. But if you think about what you can, that you're saving lives and you balanced how many lives you can save, given that we have lost so many in Maryland. I mean, just in 2022, 1,800 people, and it's now in our schools, our local schools.
Yeah, we
Yeah.
got to shut the border down. Thank you.
I don't think that has anything to do with that, and that's another conversation. Drug addiction goes back in this country for many, many, many centuries. We had a problem with crack cocaine, where it affected a lot of black people and brown people, and what we did was we arrested our way through it, and you have people in jail. Now we're trying to find solutions, right, to find treatment, because it is the right thing to do from a public health perspective. So I wouldn't blame it on the borders. It is a problem of, for example, since we had COVID, depression, all right, suicide went up, depression went up. Kids find themselves in rural areas where not having much to do. Kids find themselves in the city as well with the same problem. It's drug addiction. You had the young men that came, the family that testified last week, where his father was a lawyer, the mother, the girlfriend, the fiance, very nurtured and loved, yet he became addicted to the, painkillers, which we know this committee has worked really hard to try to prevent that, right? Because a lot of that cost, it's because of the painkillers. A lot of the cost of the issue is because kids want to try things. So it's not just one cost at all. It's complicated and layered. Thank you. Delegate Martinez.
Thank you, Madam Chair. And this is for anyone on the panel. I cut my teeth in county government, and I know particularly Prince George's County, our county health department has really low capacity. Could you guys speak to just how these programs would work with local health departments in particular?
Thank my panel here. So this, again, would be supported by the local health department. As I indicated, there is strong support under the mayor's administration. So we would, potentially provide just oversight and guidance, but this would be run by a community-based organization as is stated in the bill. We would just be there, again, for technical assistance and to provide general support.
Got it. Thank you.
Thank you. We have Delegate Hill.
Thank you, Madam Chair, and thank you for this bill. Panelists, can you just clarify, when we talk about injection sites, what kind of drugs are we talking about? Are we talking about heroin? Are we talking about methamphetamine? Are we talking about injection cocaine? What is the range of different kinds of addictions and addicts that this kind of program could help?
Thank you for that question, Delegate. Anything that anyone chooses to consume. It is about saving lives. It is about creating that holistic care. So one of the things that is really important to keep in mind, right, is that these sites started to open, again, in the 80s, 90s. Drugs looked wildly different back then, right? And that was in places where it was heroin or they had fentanyl before us. And so it was a way to curb and kind of be proactive, as we know that chemistry and the way that science works, we're going to have more different analogs as time goes on. So this is really a way to both address and curb the overdose epidemic we're currently facing and to prevent further overdoses from drugs that we can't yet predict. And so and the other thing I want to name too is that we use lots of different language, like safe injection facility, but also the sites like in New York City also allow for smoking and snorting. So they protect people who might be using in a variety of different ways, such as pills and that sort of thing. And so really allowing for making sure that it is wide, so we can, a wide breadth, so that we can bring in the most people and really try to save lives. Yeah.
Any other questions? Seeing none, thank you for being here. It is a tough discussion, but it's one that has to be, we need to have it, and thank you for your patience and for the questions in a very respectful way. I really appreciate it. Thank you. We're going to go on to the next panel. So we have Stacy Jefferson, Sarah Berry, Jessica Emerson, Ann Giddis, and Diana Rich. Will you come up, please? And will you get started?
Good afternoon, Madam Chair and members of the committee. My name is Stacy Jefferson, and I'm the Director of Policy and Stakeholder Engagement at Behavioral Health System Baltimore. We're the local nonprofit organization that oversees the services for mental health and substance use disorder in Baltimore City. I want to first thank the General Assembly for all your work and the laudable steps that you've taken to address the opioid crisis. But unfortunately, as many on the panel before me stated, we continue to lose thousands of our loved ones, family members, community members, and friends. We must continue to implement tools and strategies that are proven to save lives, and overdose prevention sites save lives. They help connect some of the hardest to reach people in our communities to treatment and supportive services. I would just like to point out in my testimony, in my written testimony, there is reference to a Canadian study that shows that there was a 30% increase in detoxification access to those services in the Canadian study. And so, again, I just wanted to mention that because I know that question did come up. I also support this bill because I know personally what it is like to lose family members to overdose. In May 2015, I lost my cousin Sean to overdose. He was just shy of his 25th birthday. And then in May 2017, just 2 years later, we lost Sean's mom, my cousin Mika, who was more than a cousin to me. She was like a big sister. And so, as I come before you today, to ask that we support House Bill 953 in order to spare other families the pain that my family felt and the loss, and that so many others, thousands of other families have felt in the state of Maryland.
And thank you for sharing your story, and the committee is very sorry about your losses, okay?
Thank you.
Thank you.
Good afternoon, members of the committee. I'm Sarah Berry, a registered nurse working for Healthcare for the Homeless, and I'm here in support of House Bill 953. The opioid epidemic that our nation is struggling with has been the reality in Baltimore long before it came to national attention. My work in opiate treatment has shown me the impact that opiates and drug war policies have on the patients that I care about. Some people are able to engage with recovery programs, like the one I work for, but a lot of people aren't able or aren't ready to stop using drugs. And there are very few resources available for people in that situation. While the rest of the state is beginning to see opiates be cut with fentanyl, in Baltimore, there is almost no heroin. It is all fentanyl, and it is killing people. I saw a patient last year, came in, had overdosed recently, been revived with Narcan. We made sure they had Narcan before leaving the clinic, and they overdosed again that very night. And they were found dead by their family Thanksgiving morning. Overdose prevention sites would prevent deaths like the one my patient had last year. It's clear that having medical care there to assist immediately with an overdose, especially in the era of fentanyl, which acts so much faster, will save lives. I also had the opportunity to go visit the overdose prevention site in New York City, and I saw firsthand how much of a difference they can make. We've talked about how many overdoses they stopped in that first year. But what I noticed is that they had to call EMS 11 times in that entire first year. And that is so many ambulance rides and hospital bills that are saved for the city. We're ahead of the curve when it comes to the severity of the overdose epidemic, which means we need to be ahead of the curve in responding to it. So I urge you, pass this bill and authorize overdose prevention sites. Thank you.
Next, please.
Good afternoon, Madam Chair, members of the committee. My name is Jessica Emerson, and I direct the Human Trafficking Prevention Project, which provides legal representation to criminalized sex workers and survivors of human trafficking. We also engage in systemic advocacy designed to prevent the exploitation of those put at highest risk, one of which is women who use drugs. As a result, I am also here in support of House Bill 953. So you've heard that the bill would authorize establishment of these overdose prevention sites, allowing for safe consumption of pre-obtained drugs. But I want to direct your attention to another benefit of these sites that's not commonly considered, which is a decrease in the exploitation and violence that women who use drugs commonly face. For women who use drugs, exposure to gender-based violence is one of the defining characteristics of street-based drug use. As a result, the establishment of safe, regulated spaces that mitigate these dangers holds great promise for reducing these harms for this population. A central theme in the experiences of women who use safe injection sites in Vancouver, Canada, was that they specifically sought out these sites in an effort to diminish the threat of violence they faced using drugs on the streets or in street-adjacent environments. Many women shared that they had been exploited for drugs or money by men in exchange for a safe place to use, and that they were commonly subjected to physical violence following disputes over the money or the drugs that the women themselves were put in charge of actually obtaining or made responsible for obtaining. For many women, these sites were described as safe havens that provide a temporary escape from violence and exposure to police. Decreasing the risk of incarceration while at the same time increasing safe usage and support lessens the likelihood of exploitation for all women who use drugs because they are less likely to have to rely on a potential trafficker for this essential assistance or to live their lives in the shadows where exploitation thrives as they merely try to figure out how to use more safely. By providing safe injection sites, sterile needles, along with first aid and other resources, House Bill 953 would reduce the harms women who use drugs face, including their risk of violence and exploitation. For these reasons, the Human Trafficking Prevention Project supports this bill and respectfully urges a favorable report. Thank you.
Next, please.
Good afternoon, ladies and gentlemen of the House, Madam Chair. My name is Diane Rich, and I reside in Baltimore City. I am here to testify on House Bill 953, Overdose and Infectious Disease Prevention Service Program. I believe in this bill because it supplies addicts with a safe place and sterile needles to use their drugs without catching diseases or dying. Research has shown that no one has ever died in an overdose prevention site. The site also provides first aid if needed. The addicts will also be able to use the resources at the site to go into treatment if they choose. The addicts need to be treated with dignity and compassion while in the throes of addiction. Please vote yes to House Bill 953. Thank you.
Thank you, and thank you very much for being here. There is another person, the Maryland Coalition of Families, Ann Geddes. Is she here? Okay. Are there any questions for this panel? Delegate Bagnall.
Thank you, Madam Chair. I have been reading about the horrors of xylazine, and I know you've spoken to some of the first aid and other wraparound services. Would wound care and wound management be part of a service that would be provided?
Yes.
Thank you. Thank you, Madam Chair.
Delegate Kaiser.
Thank you, Madam Chair. And my question is for, I think, Ms. Emerson? Is that right? Yes, the Human Trafficking Prevention Project. I'm looking at your written testimony, and if I heard, there was so much packed in what you said. And I feel like I heard you say less violence, less sexual exploitation, less problem with dirty needles, and then so many other reasons other people gave. It seems like the only reason people don't support a program like this is that they think it means government endorsement and acceptance of the drug. So I'd like you to address that point, because I think you've given all the other great benefits, but I think that's like the only argument on the other side.
So thank you, Delegate Kaiser, for that. I think you're right that a lot of the data clearly shows that these programs are helpful, that they save lives. My testimony obviously is focused on reducing exploitation and violence. I think the concept of harm reduction is hard for people because they want to stop the harm. And accepting a harm reduction model, a harm reduction program like this means accepting that people are going to die. And that is the reality of problems with interpersonal violence, problems with sexual violence, trafficking, drug use. But if we can be a part of reducing that harm and putting people on the track to getting the support they need to make their lives as safe as possible, and perhaps to get out of the life, as one of the other delegates talked about, then we are doing all that we can to mitigate that harm. And I think that's hard for people to get to, and I understand that. But we should be doing everything we can to save as many lives as possible, and that's what this bill does. It doesn't eliminate harm. It reduces it, and it reduces it significantly in really important ways. Obviously, death and overdose and all of that, but I feel very strongly about what I have heard from women who experience violence on the street. Dr. Sherman actually did a study on female sex workers in Baltimore, and 77% of them said, who use drugs, I'm sorry, I should have said that. 77% of them said they would use these spaces if they could, because they could reduce the harm that they face when they are using on the streets. That's all the endorsement I need. Those are our clients.
Thank you. Delegate Hill.
Thank you very much. I'd like to ask the second from the left. I'm sorry, I don't remember your name.
Sarah.
Sarah, thank you. So can you comment briefly on what additional supports are there transitioning people who are ready to look to break their habits? I know you had mentioned that. And for people who are not on opioids, what kind of medical support do they get if they're overdosing, and also in the socioeconomic mix of people who come in?
Yeah, absolutely. So regarding the social economic mix of people who come in, it is largely people who are homeless, unstably housed, underhoused, that kind of thing. Regarding the different types of drugs, the overdosing on stimulants works a little differently, but they have had several hundred incidents of that as well. In those situations, it's more about separating someone, getting them into a place where they can come down slowly, not be overstimulated, and it helps keep people from either getting elements of like psychosis or violence in those sorts of situations. And by getting people into low sensory areas, a dark room where they can rest, those sorts of interventions help keep people safe even when it's not an opiate overdose. And regarding the other services, there's connections to peer recovery, there's wound care and medical treatment in general. They offer Suboxone, which is a type of medication-assisted treatment for opiate use disorder, and linkages to treatment programs and other resources out there. So the whole wraparound services, it's not just the safe use space. It's everything that is available to people, including food, including laundry, including services that people just don't have. Showers, exactly. Yeah.
Thank you. Delegate Lewis.
Thank you, Madam Chair. And if I didn't already, thank you for bringing this bill. Thank you, Madam Chair. I really appreciate all of you on the panel. I'm wondering to what extent, when we talk about harm reduction, which you've spoken so eloquently of, how important is access to housing? And is that a missing piece of the harm reduction approach? Whoever is best to answer.
I can take it. Yeah. So housing is so essential, and it's the social work and social services are also available in the other services, which includes linkages to programs like housing assistance. But we know that when people are on the street, they are not stably housed, chances of using drugs goes up, and chances of using drugs in unsafe situations because they don't have a safe place to use them goes up. And so that's a huge portion of this, is that it's particularly effective for helping our most vulnerable community members who are unhoused or underhoused.
Thank you, Delegate. Any other questions? Seeing none, thank you all for coming. Thank you for sharing your experiences and for the work you do, which is very difficult, okay? Thank you so much.
Thank you again.
We have our last three witnesses for this bill. We have Rachel. Is Rachel Young here? And then we have two virtual witnesses. Will you be so kind and bring them up? Thank you so much. Good afternoon. You can get started.
Being up here alone.
No, you're, you know what? This is, as we are discussing a safe space, right? It's a safe space and a very respectful space, okay?
Thank you.
Thank you.
Madam Chairwoman, members of the committee, thank you for your time. My name is Rochelle Young, and I'm testifying before you today because I know drug users, because I love drug users, and because I am a drug user. I support overdose prevention sites because I don't want my friends to die, and I don't want to die. I volunteer with a group of harm reduction workers who test drugs at music events. We use reagents, which are chemicals that change color when in contact with certain drugs. We've also partnered with a university to borrow a mass spectrometer to measure down to the percentage the content of a drug. People line up outside our tents at music festivals to test with us, because people want to know what they're ingesting and to do so safely. At one event in 2019, we found fentanyl. The person who brought us the drug for testing did not intend to use fentanyl. She thought she had bought something else. Along with medical personnel, we were able to find the person who had sold it to her, who also did not know it contained fentanyl. He had intended to use it as well. We saved multiple lives that night, because we could safely test the drugs and provide immediate access to life-saving interventions such as naloxone in the event of an overdose. And that's why overdose prevention sites are essential. A safe, regulated, and supervised space to use drugs should not be a privilege only available to those who can afford to pay for a festival ticket. It should be something that everyone has access to. Nobody deserves to die from drug use. And for this reason, I urge you to vote yes on HB 953.
Thank you. And I want to thank you for sharing your personal story because it takes a lot. It really does.
You're very welcome.
And we
I'm happy
really
to be here.
appreciate it, okay?
Thank you.
Are there any questions for this witness? Thank you, and thank you for your time. It really matters, okay?
Thank you so much.
My pleasure. We have two other witnesses. We have Nancy Rosen Cohen. Will you be so kind and start? And you have to unmute yourself so we could hear your lovely voice. You're still muted. It's okay. It's all right. So I'm going to go to the next witness. Okay, go ahead.
I'm ready now.
Okay.
All right, sorry for the delay.
It's okay.
My name is Dr. Nancy Rosen-Cohen. I'm the Executive Director of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We strongly support this bill. I want to commend the Baltimore Harm Reduction Coalition for their excellent work. And I want to thank the Madam Chair, who's always been supportive of us in the SUD field and behavioral health field. We hosted leaders from New York City, just as other panelists have said, and they talk about saving hundreds of lives. What I want to talk about is the fact that we here in this room and all of the legislators are part of the solution. There is a solution to saving people's lives, and this bill is a major part of the solution. And the beauty of the overdose prevention centers, as we've witnessed in other countries, is that it's a public health crisis with many partners. So we have case managers, we have social workers, we have physicians, we have nurses, we have counselors, and most importantly, we have our police officers that are willing to bring people to a center, to an OPS center. And that's very, very important. As we all know, overdose sites are very troubling. We don't want our individuals to be arrested, but we have friendly police officers that will help us in this. So the beauty of it is that we all can be part of saving people's lives. And I want to thank the legislators and the leadership for helping us bring this to light this year. I know it's done in past years, but this is truly a solution. It's only one of many, but we all can save lives. And that's what we're all here for. Thank you.
Thank you, and thank you for your work. We really appreciate it. Next, we have, you're welcome, Angela.
Hello, thank you members of this committee, and thank you Madam Chair for being the lead sponsor on this bill and also for representing my district. My name is Angela Geiger and I'm a medical student at the University of Maryland School of Medicine, and I'm a student member of the organization Chesapeake Physicians for Social Responsibility. I'm urging a favorable report on this bill. The issue of overdose prevention is very close to my heart. Growing up, both of my parents were drug users and frequently overdosed. I was usually the one to find them, and this happened more times than I can even remember. As you can imagine, this was incredibly traumatic to witness as a child, and for many years, I blamed the medical system for not doing enough to help them. This was one of the driving factors for me to attend medical school, and now that I am here, I see that this is a multifaceted issue. The medical system nowadays largely recognizes addiction as a medical condition, not as a flaw in someone's character or as something that should be criminalized. However, because of the widespread stigmatization against drug users, those who need help can't receive it. We see this in the growing number of overdose deaths, especially in Baltimore, which has earned its title as one of the opioid epicenters of the United States. There's much work to be done to prevent these deaths, and one of the first steps is to allow for the creation of these overdose prevention centers. These centers have been shown time and time again to prevent fatal overdoses and prevent communicable diseases such as HIV. They help connect individuals with treatment and recovery resources. They do not increase the number of new drug users and do not increase crime in their local regions. Rather, they reduce crime in the regions that they're established in. I strongly encourage you to vote favorably on this bill to save lives and help keep families together so nobody else has to go through what I went through. Thank you.
And thank you for making time to be with us today. Are there any questions for this witness? Seeing none, thank you so much. I really appreciate it. I want to just take a minute to say thank you to all of you who came, who traveled, and for your testimony. As you saw, the committee listened. It's a tough conversation, but it's one that needs to be had, and we have had it for the last 8 years. So I want to just say thank you for having it in a respectful manner, okay? Delegate Shalega.
Thank you, Madam Speaker, and I do appreciate your tenor and tone that you take in the committee. I'd like to apologize for my snarky comment to you about the border and those here in the hearing. That's, generally not my approach, so I apologize.
And I appreciate it. That means a lot. Thank you so much. So next, we're going to move on, and I want to say safe travels to everyone who came, okay? Thank you. We have House Bill 570. It's a shorter bill, Delegate Bagnall. Public health prescription opioids deactivation systems.
Sorry.
You can get started.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, members of the Health and Government Operations Committee. For the record, I'm Delegate Heather Bagnall, District 33, Anne Arundel County, here on behalf of House Bill 570. You have my written testimony, so I'm going to summarize, and I'm actually going to eliminate a lot of what I was going to say because it's already been said. The breadth of the opioid crisis is no mystery to this committee. But one of the issues that we're dealing with is secondhand use of opioid prescriptions, where an opioid is prescribed by a provider and later left unattended and accessible and, without completing the prescription. And it can be a gateway to opioid abuse and addiction. There are many methods that exist to combat misuse and abuse of unused prescription opioids, one of which is proper and safe deactivation or disposal. There exist methods for leftover prescription opioids where they can be rendered unusable, and according to the FDA, these methods are preferable to simply throwing drugs down the drain because they entirely eliminate accessibility to those drugs. We know about our take-back programs. This is not what this bill is. The take-back programs, we have them. They're in locations that, even though they're within 5 miles of residents, about 70% of American, 5 miles of 70% of the American populace. The U.S. Government Accountability Office estimates that up to 3 in every 4 patients prescribed opioids do not properly dispose of them, allowing them to remain in easily accessible places after a prescription is no longer required. So House Bill 570 proposes a very simple solution to this issue. Put proper disposal methods directly into the hands of Marylanders who are prescribed opioids at the time of dispensing. House Bill 570 stipulates that the state will offer a no-cost-to-consumer method of rendering an opioid unusable at home alongside opioid prescriptions. This is made possible by sourcing funds for disposal units from the Opioid Restitution Fund, which the Office of the Attorney General has indicated is applicable to the methods of opioid disposals. Enabling Marylanders to render opioids unusable in a home setting will have a positive impact on opioid abuse rates across the state by reducing excess prescriptions left to sit in accessible areas. This is a proactive action. It's not necessarily going to get the existing drugs out of the medicine cabinets, but it's going to sort of provide a stopgap. The bill as it was introduced is heavily inspired by legislation introduced recently in New York. Working with stakeholders concerned with facets of the bill, including the neutrality of the language used to describe the deactivation or disposal systems, we have submitted amendments to address concerns, including the legal mechanism by which opioid deactivation or disposal systems are distributed, ensuring that the systems are made available but not required, and we have excluded hospice care as they already have their own systems, and hospitals who generally provide starter doses rather than full prescriptions.
We're continuing to work with stakeholders to ensure the bill comes to a posture for which all parties are amenable. And once again, breaking news, I got a text saying that, some of the opposition that you will see in your floor system with the new amendments are now in support of the bill, and they'll be speaking later in this hearing. So under House Bill 570, people prescribed opioids will be afforded access to another tool that they need to help combat the opioid crisis from their own home. With that, I respectfully request a favorable report on House Bill 570.
Thank you, Delegate Kaufman.
Madam Chair, members of the committee, my name is Dana Kaufman. I'm here on behalf of MedChi. We very much appreciate Delegate Bagnall working with us to address some of the concerns that we had initially had on this bill. As she had stated a couple years ago, you might remember, for those who were here, that you addressed the issues in hospice and the diversion that was occurring to be able to allow the hospice workers to be able to dispose of the medication that wasn't allowed before. Technology continues to change. We need to make sure that we're changing with the technology. That's what this bill is doing. It's yet again just another tool that we can be using at the point of either prescribing or being able to put it into the hands of the end user to be able to dispose of it in a very safe manner, both for the individual as well as for the environment. So we're going to continue to work with Delegate Bagnall, but we appreciate her support and we very much appreciate the intent and the need for this bill. Thank you.
Thank you. This is the sponsor panel. Are there any questions for the sponsor and her panel? Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Bagnall. And I know you know we had a similar bill last week. I'm curious, I get the intention. My question is the mandatory nature, right? So if every time I get a prescription, I get one of these, and I'm actually completing my prescription, have you considered, or are you considering that it's offered at the time, but that people can decline it?
Thank you for the question, and in fact, that is the intent of the amendments, because we didn't want to require that it be dispensed, especially as we're dealing with folks who are have chronic pain management, and obviously they wouldn't need these systems with every prescription. So yes, it has been amended to be offered at the time of dispensing, but not required.
Sure.
And I'm just curious about what your communications with the manufacturers who the bill would suggest that they would be voluntarily offering these things. What feedback are you getting? Are they willing to give enough of these devices that they can be shared at no cost?
We're still working out the details of whether it would be pre-purchasing of them through the restitution funds or whether it would be a reimbursement, and we're working with the health department on that issue.
Any other questions? Seeing none, thank you so much. We do have Ian Goldstein.
Hi.
Good afternoon.
Good afternoon. How are you?
You felt like you wanted to touch that light, right?
Yeah, it says
No
do not
need,
touch.
no
so,
need, no need.
Yeah, so I'm not going to touch it.
No need to do it. I saw you.
Yeah.
Go ahead.
Chair Pena-Melnick and members of the Health and Government Operations Committee, thank you so much for the opportunity to testify before you today in support of HB 570. My name is Ian Goldstein, and I am the Government Affairs Director for Verde Environmental Technologies. We are the maker of the patented DETERRA drug deactivation and disposal system. DETERRA utilizes proprietary activated carbon, which permanently deactivates opioids and other dangerous drugs by adsorbing and permanently binding drugs, rendering them inert, unavailable for misuse, and safe for the environment. I applaud the committee and Delegate Bagnall for her leadership on this issue, for introducing this bill aimed at lessening opioid misuse initiation rates with a common sense approach that to preventing misuse before it starts. As you all know, in 2021, over 108,000 reported overdose deaths in the United States, including 2,800 Marylanders. More must be done to prevent addiction before it starts. Many Marylanders have extra medication bottles in the medicine cabinet, and nationally, more than 60% of people hold on to opioids indefinitely, greatly increasing the risk that a child, friend, or relative could misuse them. Co-dispensing a deactivation and disposal system with an opioid prescription greatly reduces potential poisonings or initiation to drugs with addictive properties. Co-dispensing also, studies show that co-dispensing increases rates of proper disposal and changes disposal behaviors. According to the National Institute on Drug Abuse, 80% of heroin and other illicit opioid users first began misusing prescription opioids. Further, according to the 2017 National Survey on Drug Use, 40% of respondents obtained prescription opioids from friends and relatives, while only 30% received a prescription from a physician. I testify in front of you today not only as a representative of DeTerra, but also as an individual who lost his own family member to a prescription drug overdose. March 1 marked the 7-year anniversary of my first cousin Alexia Springer's death. Alexia was a 17-year-old senior at Centerville High School in Virginia, where she was a homecoming princess and a good student, hoping to graduate and go on to dental school. On the night of February 28, 2016, Alexia went to a Skittles party where she traded medications with friends and was given a lethal dosage of morphine she mixed with other prescription medications. That night, Alexia's heart stopped as her friend slept in her bed next to her. Our family, like millions of other families across the country, has been forever impacted. Co-dispensing, and I'm almost done, sorry. Dispensing at-home deactivation and disposal at the time of prescription is an effective tool to encourage patients to remove leftover medications from the home, decreasing the risk of possible misuse or diversion. This legislation will be an important policy to support and expand Maryland's efforts to prevent future substance misuse while tackling the challenges of the current epidemic. Thank you for the opportunity, and I look forward to answering any questions.
I'm sorry about your loss.
Thank you very much.
Thank you for sharing it. Are there any questions for this witness? Seeing none, thank you so much for coming.
Thank you.
Really appreciate it. Next, we have an unfavorable, Ms. Locklear. Good afternoon.
Good afternoon, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Association of Chain Drugstores and Guilty as Charged. I am the texter. Just last night, we did receive the new amendments to the bill. I did share them with members. We're reviewing them, but I do think that they get to all of our concerns. There's been a variation of this bill probably over the last 10 years that the committee has seen. So we're really looking forward to working with you all. I do just want to echo, and we couldn't agree with the DEA more, just wanted to leave the committee with what they have to say. And the best approach for consumers and public health and safety in this space is a broad, voluntary approach with many supply chain entities involved in the process. So really looking at it from a shared responsibility. So I'll go ahead and end my comments there. Looking forward to working with the sponsor and the committee. Thank you.
Thank you, and thank you for working with the sponsor. We really appreciate it.
Absolutely.
Are there any questions for this witness? Seeing none, thank you for your time and all your efforts. This actually concludes the bill hearing on House Bill 570. Next for the committee, we have the wonderful Delegate Eversole. House Bill 681, Recovery Residence Grant Program Establishment.
And I have two people.
Welcome.
If you'd be welcome to have two people come up with me.
Yeah, bring
Roger
your panel.
Hall, if he's here, and John Pica. Thank you. This is truly a rarity for me. I don't get in front of HGO very often.
I know.
So I'm pretty excited.
Thank you for being with us.
Yeah, well, you know, it worries me because I'm out of my depth here, but we'll see what happens.
Oh, you're among friends, so it's okay.
Yeah, most of them like me, it seems. I bring to you a bill that will help to bolster and help recovery residences. I imagine many of you know what they are, so I'll keep my description of them short. I have people who can describe them even more fully. I do have friends who are in rehab, and the business of recovery residences, they don't refer to as halfway houses. They like to refer to them as three-quarter houses if they can. They say you're really on your way. They are alcohol-free, but obviously people can't just turn out. Oftentimes restarting their lives is a slow process. And recovery residences supply that. And I was entreated by Senator Gazzoni to cross-file a bill with him where we would create grants in the amount, hopefully, of as many as $500,000 toward establishing and keeping the recovery residences sound and sure. There's a number of requirements in the bill. There have been some amendments suggested to the requirements in the bill, and I will leave them to the experts in this particular case. I just know that when the idea was presented to me, as soon as I understood what it was, as well as I do, I thought, well, what a privilege for me to be a person who gets to bring that before a great group of people like this that I don't often get to hang out with. So I hope you'll give it a favorable report. And with that, I'll turn it over to Roger, and then I think Senator Pica will go last.
Thank you, Delegate. Good afternoon. My name's Roger Huff. I am a man in long-term recovery and a Howard County resident, and I appreciate you letting me come and speak with you today regarding transitional housing. We believe that it is important to break the chain from treatment, street, and it happens with recovery housing. And our recovery housing specifically is focused on a level 2 house. And what a level 2 house does, it provides peer support, no clinical support. And we see an average length of stay with folks staying with us for 6 to 8 months. And similar type homes, we're having a hard time being able to have our ends meet, providing peer support, providing technology to help folks as they navigate through, whether that be job seeking, whether that be having, some folks that come in to talk about finances and other ways to get their lives back in order. So we came up with the idea of this bill to be able to provide funds to smaller operators that are working in our community, that are taking in 6, 7, 8, 10 souls, and being able to support them and their families, knowing that they're going to have a safe place to stay. And one of the things I'd like to highlight on here in my last 40 seconds is that we have 3 homes in Howard County, 18 total. And throughout the pandemic, we, as a group, decided that we would reduce our population, and we did not have one episode of COVID in any of our homes because we were able to reduce our census to 1 per room. And it gave those folks the ability to maintain their jobs, not have to worry about, are they going to get put out onto the street, and allowed their families to know that they were able to stay there safe. So this is the level of support that we're talking about here in our communities, of providing safe, structured, and affordable housing.
Thank you. And I want to say thank you for sharing your story, okay?
You're welcome.
It matters. Go ahead.
Madam Chair, John Pica on behalf of Living in Recovery. We have Senator Gazzoni sponsored the bill on the Senate side, and I want to just bring to Council's attention that there have been amendments that we have agreed to, and that is to take on page 3 to strike the language from lines 7 through 25. We also would like to keep this at level 2 recovery residences and not open it up to 3 and 4 recovery residences, or levels 3 and 4. The level 2 of recovery residences do not accept insurance or Medicaid money. They rely solely on grants and donations. Levels 3 and 4 are much larger organizations that stand on their own and do take insurance and private insurance money. We hope you resist any attempt. I believe the Department of Health, I don't know if they've contacted the committee, they might have amendments, but I would hope the committee would keep this to level 2 recovery residences and not open it up. I know that that's the position of the sponsor. And also there's another effort to open it up to operating and capital grants. And I would hope, I don't really know of any other sources of state money that gives out to both. I would hope that you keep it just to operating grants. These are residences that individuals who come out of rehab are sometimes told not to go back to their places where they were, where the drugs are. Recovery residences give them an opportunity and a comfortable place to continue their recovery. With that, Madam Chair, I would ask for a favorable report, and I'll submit amendments to council.
Thank you. We have actually a Maryland Department of Health letter of support with some language in there, but thank you for forwarding the amendments to council. Really appreciate it. Are there any questions for the primary sponsor and his panel. Delegate Lewis?
Thank you, Madam Chair.
pleasure.
Thank you, Delegate Eversol. You have at least one friend in this room.
Who is, are you going to tell me who it is?
But thank you for this bill. We were just talking about the importance of access to housing as a kind of treatment intervention for folks experiencing substance use disorder and other challenges. I was wondering if this grant program, looking at the bill, it says grants, organizations that would be eligible for the grants would be existing nonprofits in good standing. But I'm just wondering if the existence of the grant program might catalyze the creation of more residences. You know, how we have a housing shortage, particularly for people who really need it. And I wondered if this grant program that you're proposing could help solve that problem.
That's an interesting question. I'm going to let experts do it, but I think this is why we come back every year. If this begins to be very successful, then probably would entreat the committee, or I'd be happy to reintroduce the bill for expansion if it would incentivize it.
Thank you. I think you just used up my one answer. Madam Chair, unless you...
Oh, I will indulge you. Go ahead.
Thank you. So if the gentleman who's an
Feeling
expert...
generous.
Thank you, ma'am. If the gentleman who's an expert could answer.
I just want to draw a distinction. Level 2 homes, folks have already found some stabilization. So with Level 2 homes, they have less clinical support. So it's folks that have some more autonomy and agency, so they're going back to work. They're more focused in the community. They're taking themselves to meetings. So they have some, they have some routine going on. We do need higher level homes that can stabilize people and provide clinical support in both medical and mental health needs for them. That's not the level of the homes that we're looking at here for support. We're looking at long-term as they start to turn the corner to come back to a life.
My pleasure.
Sorry,
Any
I didn't
other-
know that, Maury. I would have stayed quiet.
No, it's okay. We did it for you. You can't say you were not treated well here
Next time,
and that you do
next
not have
time
friends.
I'll understand much better. Thank you.
Okay, any other questions? Seeing none, thank you very much. And thank you for sharing your story, okay?
Thank you,
Yes,
Madam
ma'am. I
Chair.
appreciate you.
Next, we have 3 virtual witnesses. Will you be so kind and allow them in? They're not in. Tom Bond, Tony Amy, Samuel Berman. You don't see any of them in the waiting room? Oh, Susan Pampa is there. Great. Yes, please. Thank you. Good afternoon. Will you be so kind and get started?
Yes.
Thank you.
Starting with me?
Yes, please. Thank you.
Thank you, Madam Chair, and thank you to the members of the committee. I'm happy to be here to represent the National Council on Alcoholism and Drug Dependence. My name is Susan Pampa, and I am the Associate Director there. We are very much in support of House Bill 681 with the amendments that have been mentioned. Housing is a basic human need, and that's no different for people in recovery. Recovery residences are meant to provide a safe and healthy living environment while supplying needed recovery and peer supports. Several years ago, Maryland adopted recovery residence standards established by the National Alliance of Recovery Residences, known as NARR. This bill will in part create a fund for recovery residences certified at a level 2 to assist with the operating cost. As the bill specifies that to be eligible to apply for the funds, a recovery residence must be certified at level 2. However, there are additional requirements that are listed in the bill, and they go beyond what the standards require and create a level that does not exist within those that Maryland has adopted, as has been mentioned in the original panel. NCADD Maryland also does not believe some of those eligibility requirements are appropriate for publicly funded recovery residences. We have worked with the organization that requested the bill and the sponsors on amendments, and we believe there's agreement on amendments to strike the added eligibility requirements. With this amendment, we urge a favorable report. NCADD Maryland stands ready to work with the department on ensuring recovery residences and all recovery support services are going to be effective, non-discriminatory, and appropriately funded. So we urge your support of this bill. Thank you very much.
Thank you for being here with us. We appreciate your testimony. Are there any questions for this witness? Seeing none, thank you so much for being with us. I'm going to
Thank
go
you.
back to Tom Bond and Tony Amy. Are they there? No? Okay. Well, this actually will conclude the bill hearing on House Bill 681. Thank you very much for being with us today. Next, we have House Bill 869. Delegate Boyce. Are you testifying on behalf of the delegate?
No. I'm Barbara Blaylock. I'm here for the Funeral Consumers Alliance.
Excuse me?
The Funeral Consumers Alliance?
Yes, but we're waiting for Delegate Boyce. Will you be so kind and just wait a second?
Sure.
Thank you. And I don't see Delegate Smith, Delegate Bartlett, Henson, Buckle, Kelly, Johnson. I think I might just go with yours, right? Let's go, let's do it. Oh, they're not here? Okay. Well, this is a little odd. Why don't we, where are they? Are they nearby? Okay, do you want to get started while they come? Okay, thank you. Who has the cannabis one? 1 minute. Buckle. Is Buckle here? No, he's not here. You go ahead, get started. That would be great. And that works great because you have 15 witnesses. The other ones only had 2 and 3. That's a shame, but go ahead. Yeah, go ahead. Will, can you ask staff to call Delegate Johnson's office and tell the witnesses to come, please? Thank you. Delegate Johnson, thank you for your flexibility.
Absolutely. Thank you for bumping me to the front of the
And
line.
so I'm calling now House Bill 1135. Delegate Johnson, will you please get started?
Madam Chairman, I see Delegate Boyce just walked in. While I get my panel, would you like to let her proceed?
Sure. All right, we'll put it on hold. House Bill 869, Delegate Boyce.
That's the way we roll in this committee.
Thank you. It's going to be quick, I think. And you know I didn't know y'all was across the hall. I'm such an idiot.
And is Barbara Blaylock, will you come up with the delegate, please? And this will be the panel. Go ahead.
Thank you so much.
My pleasure.
And good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the Health Government Operations Committee. For the record, I am Delegate Regina T. Boyce, here to present HB 869, Department of Environment Study on Death, Care, and Funeral Practices. Now, HB 869 requires the Department of the Environment, in consultation with the Maryland Department of Health, the Maryland Department of Labor, and institutions or organizations with expertise to conduct a study of the environmental and public health impacts of death care and funeral practices in the state, submitting the study, of course, of the results by October 1st, 2024. Examples, of course, of death care and funeral practice include mausoleum burials, casket-only burials, natural green burials, cremation, alkaline hydrolysis or water cremation, natural water cremation, and natural organic reduction. The study will review the health impact of these practices on air, land, water, and the environmental impact to carry out these practices, such as energy use, chemical use, and materials used in these practices. HB 869 further requires that the study provide mitigation practices for each of the death care and funeral practices to assist in lowering the environmental and health impacts. You know, this bill touches on a topic that's, quote, you know, not very discussed often. It's death, and it's hard, it's scary to confront our mortality even more. It's hard to think about the remains of a loved one ourselves. You know, how do you want your remains managed, and how do we manage the remains of our loved ones? And there are many options about which death care and funeral practice is best or most environmental. However, I would argue that generally all practices available have environmental and health impacts. But through this study, we can make the determinations of which method we would like to use based on how much of an impact it will make. An individual can also decide which mitigation practice to use for practices that may have higher impacts to lower them. And I want to also be clear that this bill is not about setting up one practice above another. Bill is not to say that one should do one or another. I think this study, which has not been performed anywhere, just says, what are these impacts? And as a consumer, unfortunately, how, what can I make a decision on? As we know, a lot of natural and green burials are coming about more and more because a lot of folks don't either, funerals are costly. And so this is just a way to look at what those different options are, not to put one against the other. And so I thank you for your time and consideration of HB 869, and I ask for a favorable report.
Thank you for being with us today. Welcome.
Thank you.
Will you please get started?
Yes, I'm Barbara Blaylock. I'm the president of the Funeral Consumers Alliance of Maryland and Environs, FCAME. We are the local affiliate serving Maryland, the District of Columbia, and Delaware of the National Funeral Consumers Alliance, which is the only nonprofit that works to advocate for consumers and educate them about their after-death care options. I am incidentally a retired primary care physician and a passionate environmentalist. So thank you for the opportunity to provide this testimony. This bill would require the State Department of the Environment to conduct a study of the environmental and public health impacts of death care and funeral practices, both in the state and in general. FCAME supports HB 0869 because it will help Marylanders make wiser and more prudent decisions about death care at this time when the effects of climate change and environmental pollution are of increasing and even dire concern. In most conventional burials, the body is pumped with toxic embalming fluid, placed in a steel or wooden casket, and buried within a concrete-lined vault 6 feet underground. This process consumes trees, steel, and cement, generates acres of lawn that are counterproductive to natural ecosystems, and utilizes toxic chemicals that expose funeral workers to occupational hazards and even leach into the soil. Flame cremation, as opposed to water cremation or alkaline hydrolysis, an increasingly popular choice, is often considered more eco-friendly than conventional burial, but it entails heating the body to 1,800 to 1,900 degrees by burning natural gas, releasing significant amounts of carbon dioxide, as well as variable amounts of particulate matter and chemical air pollutants into the environment. Oh my goodness. The newer options, alkaline hydrolysis and natural organic reduction, supposedly are better, but there's a lot of debate about how much better they are. So this bill would give Marylanders the opportunity to have a neutral set of facts that would allow them to make more prudent decisions. I'll stop there, I guess.
Thank you. Thank you for your testimony. We appreciate it. Are there any questions for this sponsor panel? Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Boyce, for bringing this bill. It's interesting. It is. And you're right. I don't want to think about dying, but I'm glad that you're making it easier. So I just looked at the letter from MDE. It's favorable with amendments.
Yes,
Basically,
yes, I've been working with them the entire time. I'm sorry, through this process, so I do accept those amendments. I think it's just a matter of using current resources so they can have a study within a year versus doing something full that actually costs probably $500,000
yeah, that's what
in a
the
couple of
fiscal
years.
note. Okay, thank you so much. Thank
You're
you,
so
Madam Chair.
welcome. And can I quickly add, Madam Chair and Delegate Lewis,
If it's okay, Madam Chair.
Is it okay? Yeah. I just want to also say that this bill also comes about due to an issue in my district where there was a lot of opposition against a crematory that was going to open at a predominantly African-American and kind of loved, respected funeral home. And there was just the tension between, quote unquote, what is better, and the one wasn't better and one is better. And so, this bill comes from that, again, to say we can't kind of just pit one thing against another and say that this one thing is bad and this one is good, but rather to say that, again, all these practices, we all leave a footprint of some way, shape, or form, but this would actually just kind of end that debate, show that they all have an impact, but also shows what option you would like to do, again, to kind of limit that footprint. So I just want to put that out there.
Okay, there are no other questions. I do have actually a request.
Yes.
Because the fiscal note, it's over $500,000. I
And
know you're
it's
working
in its
on-
current form?
Yes.
Yes, I think, Madam Chair, with the department's amendments, it brings it down.
Will you be so kind and get a letter from them to say how much does it bring it down to? Okay?
Yes,
As
ma'am.
you know, we're,
Yes, ma'am.
yes, thank you. I appreciate it. Any other questions? Seeing none, I want to thank the delegate for her bill and her witness. Thank you for being with us
Thank you
today.
so much.
We really appreciate it. This actually concludes the bill hearing on House Bill 869. We're going to take, before Delegate Johnson's bill, we're going to take Buckle, so that you don't have to, Delegate Buckle, so you don't have to wait, okay?
Thank you. I apologize. I was downstairs in
It's
the,
okay.
whatever we call it, meeting of Ways and Means when I got the notification.
So I'm calling now House Bill, that concludes the bill hearing on House Bill 869. Next, we're going to House Bill 685, Delegate Buckle, medical cannabis, employees in healthcare settings caring for qualifying patients exemption. Delegate Buckle, welcome to HGO.
Thank you, Madam Chair. It's been, I think, several years since I've been here, and you'll realize why. I'm a little bit out of my depth with respect to the particulars of the bill, and I certainly leave that to the discretion of the committee and your able staff to work through any permutation of the bill that would make it better. The intent of the bill is very simple. We believe that medical cannabis has an effective role to play in the treatment of patients that are within certain types of facilities. The bill very specifically discusses and relates to healthcare facilities such as assisted living facility, an intermediate care facility for individuals with intellectual disabilities, a home health agency, a hospice care program, related institution to that, or a residential service agency. It's not about hospitals or other types of places that are governed by their own laws. And the intent of the bill is to clarify and make certain that caregivers or medical, there's a suggested amendment from the Maryland Commission, from the Medical Cannabis Commission, that suggests rather than use the word caregiver, which is somewhat of a term of art, change it to designated medical personnel, to allow them to broaden the number of individuals to whom they can dispense properly prescribed medical cannabis for medical purposes, whether they be palliative care, whether it be anxiety care, whether it be seizure care for people who are there. I know Delegate Johnson has a bill coming up that relates to somewhat similar issues. It may have a broader scope, but I'm sure he's very prepared to discuss that. But that is the intent of the bill, is to say that there was at one point in time an artificial limitation of you could prescribe to 5 individuals. So if you were the designated person who actually administered the medication, you could do it to 5 individuals. And so some of these facilities that where medical cannabis has become a broader form of use, they're running into a problem, particularly in smaller communities and sometimes underserved communities that don't have a lot of the facilities or have a lot of personnel to do it, that they didn't want to run into a problem where they couldn't dispense the medical cannabis that was prescribed appropriately to enough individuals within the facilities. We wanted to remove any limitation. The commission has said they believe that you might already be able to do this. They have suggested an amendment. If the committee chooses to take the bill up, I'd be happy to submit that, changing that caregiver designation to designated medical personnel. And that is really just the intent of the bill. It's to make medical cannabis for those who need it and those who are in these particularized types of healthcare facilities to have easier access to it, and to remove, if it's a real administrative burden or a perceived administrative burden, upon the caregiving facilities and the administration of the healthcare entities themselves. That's all. Thank you.
You explained it very well. Thank you. Have you seen the letter from the Maryland Department of Health?
I have not. I don't believe.
And I'll make sure that you get it.
Oh, yes, I have.
Okay.
It's on the back, stamped with something else, yes.
And it's the same concern they raised as Lifespan Network, which basically they said that because this bill states employee, it will place employers in a direct conflict between state and federal law, because the employer will not have a direct role in the process until there's a resolution between state and federal law, because, cannabis is still a Schedule I. Is the same concern that the Maryland Department of Health has as lifespan as well?
And that seems to be a terrible conundrum in this space. You know, we're going to have a debate on the floor of the House, all of us tomorrow, on legalizing cannabis, not for medical purposes, but legalizing it for recreational purposes. And we have to recognize that as far as the federal government seems to be concerned, that's illegal. I'm most concerned, quite frankly, about how, and your committee stands at the tip of the spear on this issue, how do we provide this in a way that has a medical and therapeutic benefit to real people and real patients without running afoul of federal law? And that's really the goal of this, is so that these facilities can find a workaround. I mean, obviously, you have the ability to dispense it. So if the suggestion is we can't have employees dispense it because then we're afraid the feds will somehow take action against us, this is talking about people who may not have the ability to dispense it to themselves because of some type of intellectual disability or physical disability. They're in hospice care where they're actually just frankly too weak or in and out of consciousness sometimes. How do we get around that? I understand the concerns of the department, but I'm also a big believer in, I don't think it likely that the federal government is actually going to do anything about these issues. I practice law for a living, as I know you have at different times, Madam Chair. We're very, very good at finding potential arguments of that 1 in a million chance it could go wrong. I happen to think in this particular circumstance, given the prevalence of medical cannabis in the United States of America, the federal government would be shutting down hospitals, hospice cares, and health departments from California to Maine if they tried to enforce some type of prohibition of that nature.
Yeah, we have another bill, 2 more bills actually dealing with in the hospital setting.
Right.
So it's an issue that, we're going to have to give it some serious thought.
Right, and I hope that if you do something in that hospital setting, that you can include, some of these settings for these particularized patients, some of whom particularly, I think, hospice and the individuals that may have significant disability syndromes, that this really helps them to control some of the symptomology. I don't want to leave them behind in a way that enables medical cannabis to be dispensed legally, lawfully, and safely through our state system.
Thank you. Are there any questions for the delegate? Delegate Riley?
Thank you, Madam Chair.
My
Yes, it's
pleasure.
kind of just a follow-up to Delegate Buckle, what you just said. So we are going to legalize recreational marijuana. So those folks that work in the dispensaries, the retail markets, and so forth with that industry, aren't they employees?
They are. They certainly, I know from my legal practice, having, represented someone who owned a dispensary in connection with, they are certainly employees, and they obviously dispense what is a federally illegal substance to individuals on a daily basis.
Thank you very much.
Yes.
Any other questions for this witness? Seeing none, thank you very much.
Thank you very
Delegate
much, Madam
Buckle.
Chair. Have a good afternoon.
You too. This actually concludes the bill hearing on House Bill 685. Next, we're going to go to Delegate Johnson, House Bill 1135. And that's Delegate Johnson, Healthcare Facilities Use of Medical Cannabis. This is a joint hearing with Economic Matters, and I have actually Delegate Pruski here from Economic Matters. And feel free to ask any question, let me know. Good afternoon, Delegate, and thank you for your flexibility.
Good afternoon, Madam Chairman and committee members of the HGO. First, I'd like to thank Delegate Buckle for presenting a lot of my bill. That doesn't happen often, but I'll take it. For the record, I'm Delegate Steve Johnson, here to present House Bill 1135, Healthcare Facilities, Use of Medical Cannabis. We have seen in this committee, we have taken on the issue of medical cannabis before, medical cannabis in school. As a matter of fact, the young man to my right was here about 3-4 years ago for this very issue in the school setting. It was federally illegal at the time, but this committee found a way to work around to make sure that we take care of our Maryland citizens. We've seen Connor Sheffield grow, get healthy because he was able to use medical cannabis, and he's been a strong advocate for the medical cannabis and its use in different settings. And now he's back to talk to us about the right to have their medical cannabis legal, medical card, medical cannabis in the hospital setting. We talk a lot about a continuity of care in this committee. People being able to have their medicines, being able to make sure they stay on their regimen, their medical regimen. We've also heard how dangerous it is not to be able to get your medicine or stop taking your medicine. That should be most evident in places of treatment, like our hospitals and other facilities. We all know that we worked to find a solution when it came to schools and our buses for our medical cannabis patients that needed their medicine. We also all know that the federal government is our sticky point. You just heard Delegate Buckle, same situation. We're going to hear more bills. We know this is a sticky point when it comes to medical cannabis, when it comes to banking, anything cannabis, and it's going to be even worse when we start tackling our recreational cannabis. So what we're looking for here today is a way that we can work a solution to where our patients in a hospital who need their medical cannabis have access to their medical cannabis for continuity of care, for them to stay healthy, for them not to backslide, for them not to get sick, and God forbid for anyone to get sick enough to pass away. We have to find a solution because the feds aren't doing it. We have to find a solution to take care of our Maryland citizens. And I have no doubt that the folks on this committee surely have the ability to where we can find a workaround solution for medical cannabis in a medical facility where they need their medicine. For these reasons, I'm asking for a favorable report on House Bill 1135, and I'd like to turn it over to my panel.
Thank you. And if I may, I just saw Delegate Bartlett here. Delegate Bartlett, we had called, the bills, and because people were not here, we went on to Delegate Johnson's. No, I saw you, but earlier, his witnesses were up in his office about 20 minutes ago, and we made them come down. So I apologize. We'll call you if you have something to do. We'll call you and let you know just before he ends, if you want to go back to the committee or to your office. But you could stay here and watch. Not a problem. Go ahead. Thank you for being flexible, okay?
Good afternoon, Madam Chair and members of the committee. My name is Connor Sheffield. I'm 18 years old. I'm a full-time college student and the executive director of the Connor Sheffield Foundation. For those that are not familiar with my condition, I suffer from gastrointestinal dysmotility and dysphagia. My progressive condition has resulted in an ileostomy and a foot of my bowels removed. I have to use medical cannabis to be able to eat, to be able to drink, to treat my pain and my nausea. And after trying every single medication available for my condition on the market, this plant is the only medicine that works for me. I sat in the same chair 3 years ago fighting for the right to take my medicine at school. Because of that law, I was able to attend and graduate from high school alongside my peers. Today, I'm here because I need your help again. Medical cannabis patients, and especially pediatrics, have been completely forgotten, denied real access to their medication. First, it was in public schools. Now it's in hospitals, and even in hospice. This year, this week, legislators and dispensaries are fighting over regulations, taxes, who gets licenses, who can make the most money off of this plant. And I have to sit here and beg to use the only medicine that works for me. I'm stuck in a limbo as my disease progresses, turning down several procedures which have a chance to make my life better, including a bowel transplant or an ileostomy reconnection. But I can't even explore any of these options because I can't take my medicine with me if I go into the hospital. I know what will happen to me if I go into the hospital for an extended stay. I will drop weight, I will be in immense pain, and I will suffer. I will get worse. I have to think about which option has less of a chance of me dying, not which one will save my life. Imagine if you were me. I'd hope that you would fight too. Thank you.
Thank you. And thank you for sharing your personal story and for your advocacy. Who will be next?
My name is Trisha Sheffield. I'm Connor's mom. and I'm his medical cannabis giver. First, I need to make clear that cannabis has not cured Connor, but it is the only medication that has given him a gift of the quality of life. There are some things that my family doesn't like to talk about, and I want to first apologize to Connor for what I'm about to say. Okay. I know that he looks strong today because he has to be, but Connor does have a progressive disease, and he is slowly declining. Even though we have cannabis to help him, his intestinal rehab transplant team has advised us he is in a dangerously low category of the first percentile in his weight. He is slowly starving to death and doesn't have any more weight to lose. His doctors want to help Connor with other options, but we can't even address any of it because of the way things are right now. I'm sorry. Connor has multiple care teams, but his primary care is at Johns Hopkins Hospital with no current access to medical cannabis. Along with thousands of others, we need the ability to have access to cannabis and access to healthcare at the same time so that people like Connor have a chance of wellness without suffering. The options will tell you, the opposition will tell you there is no medical use for cannabis. This state of Maryland and 45 other states with medical cannabis programs will disagree. The opposition will say that there is not enough research. It's there. They choose to ignore it. I'm a mother, and my sole purpose is to make sure that my kids have a safe and healthy life. So please forgive my emotions. But we may not have another year. The thought of the hospital stay for any reason terrifies our family. Imagine being me, having to listen to the opposition saying their fear is the loss of funding, knowing that their fear is addressed with a safe harbor. They have an out. We don't. I believe in this committee, and I know that you guys are going to be able to help us somehow. Thank you.
Thank you for sharing your story. I know it's sorry. You know, I know you for a few years. You don't have to apologize. I know it's very emotional. So, you know, thank you for sharing it, okay?
Thank you.
Can you make sure she gets some water, please? All right? Thank you. Just take your time, okay?
Thank you.
You're welcome. Next, please. Will you be so kind?
Hi there. My name is Laura Barrett Nutting, Nurse Laura in the medical cannabis industry in Maryland and across the country. It's kind of hard to try to be lighthearted at all after you hearing that story. I hope that it impacts you like it impacts me, even though I've heard the story many times before. I am a registered nurse. I worked and was trained very well at Hopkins, and I've worked in multiple other places. I currently represent multiple organizations, one of which is called the National Clinical Director Consortium. We're a group of pharmacists, nurses, and doctors who support patients in accessing and using their medical cannabis. We're not prescribing, we're just sort of helping people understand how to use their medicine. And what I just want to say regarding that is that for people like Connor, it's not even about the THC. It's not about if they can just get some THC and get a little high, then maybe they won't know what's going on and they won't feel the pain. It's that all of these cannabinoids in the plant, which many of you might not just have had a chance to be educated on yet, they make a difference working together. It's that whole plant that works together to help Connor to move his bowels at all, to feel better, to stimulate his appetite. But it's not just Connor. So for me, I love Connor. I work with the Connor Sheffield Foundation, but for me, it's about all the other patients too. I have people that I've helped, along with their providers, to get off of opioids, and they're dreadfully afraid to go into the hospital and be prescribed opioids. I have people with children with seizure disorders who are afraid to go into the hospital because the only thing that has worked is cannabis. It might not even be a lot of the THC. It's mostly CBD with a tiny bit of THC. But they can't go into the hospital because they won't have that medicine available, and the other drugs available just don't work the same way. There are so many people that need this medicine, and they need access to it. and for that continuity of care to reduce harm as a nurse, mostly because it's an ethical dilemma for me working in the hospital to know that a patient is sneaking in their cannabis, and they're afraid to tell the nurse, they're afraid to tell their providers, but they're using it anyhow. And then where do we go if they have some kind of drug interaction? Because they were afraid to tell me that they were using their medicine. So please consider supporting this.
Thank you for taking time off your job and being here, okay? We have Shanita Lewis as part of the panel, and then we'll open it up for questions. This will be the first panel. Hi, good afternoon.
Good afternoon.
How are you?
Nervous.
You don't need to be, just take a deep breath and talk to us from your heart.
And I want to thank you for the opportunity to be here today to testify in support of HB 1135. My name is Shanita Lewis. I hold a master's degree in medical cannabis science and therapeutics. I am a proud Army combat veteran, and I am the executive director of Veterans Initiative 22, a nonprofit organization named in honor of the previously estimated 22 veterans who commit suicide daily. I say previously as that number has increased twofold to 44 veterans a day. This underestimation is to deaths attributed to intentional opioid overdoses. Opioids are the #1 prescribed medication for PTSD symptoms. You see, veterans are twice as likely than that of civilians to be vulnerable to both suicide and to overdose. As I wrote this testimony, the word that I found most prominent was mission. How does this bill advance VI 22's mission for veteran suicide prevention and the Maryland General Assembly mission to enact laws necessary for the welfare of this state's citizens, and also the Maryland Hospital Association's mission to advance health care and the health of all Marylanders? This bill does so by expanding compassionate access to medical cannabis patients in a hospital facility to the 24% of combat veterans who suffer from PTSD. It increases patient welfare and eases the fears of eventual hospitalization to the 1 in 5 veterans who already use medical cannabis for PTSD symptoms and who are 3 times more likely to experience relief than those who do not use cannabis. It offers an alternative therapeutic option to the 1 in 9 veterans that reportedly receive no relief from existing pharmacotherapies. It offers dignity in death to those who are approaching the end stages of life. It has the potential to advance the health care of all Marylanders by opening up opportunities for much-needed medical cannabis research. And finally, it honors the 83% whom have served and sacrificed that support medical cannabis by offering them the autonomy over their health care that they have so rightly earned. I thank you for your support in this bill.
Thank you for your service and for sharing your story, okay?
Thank you so much.
You're welcome. Are there any questions for this panel? Delegate Chisholm.
Thank you, Madam Chair.
My pleasure.
And thank you, Delegate Johnson, for bringing this to field. It does feel like yesterday you and I were working with Connor, and I feel like I've watched him grow up, and he slept on my couch during the hearing last time because it was so long. So you almost become like family to me. So obviously, we talked about this bill over the last month or so, and I know that your mom and everybody's worried about opposition, so I started to look out for it and find out, is there going to be any opposition? And obviously, there's a little bit of opposition, but it's coming mostly from the hospitals, and I'm like, well, what do the hospitals give some of these patients? And one of the drugs I saw was Marinol, and if you could you tell me in the committee the difference between a drug like Marinol and the little bit of THC that you're required in order to survive at this point?
Of course. So Marinol is a synthetic only of THC. It has none of the other cannabinoids that are required in the medication that I take. In my instance, I require what's called CBG, which is a totally separate thing from THC. THC is just one small part of the plant that I need. Marinol is only the synthetic of THC. CBG helps me with my gastrointestinal kind of issues. It helps make me feel hunger. It helps move things through my bowels. as I mentioned, THC is only one small part of that. Other parts that are separate would be CBD, CBN. This is something that Nurse Laura was touching on, that they offer this synthetic THC, but that is not the only part of the plant that people like me require.
Thank you, Madam Chair.
You're welcome. Delegate Lewis.
Thank you, Madam Chair.
welcome.
Thank you to the sponsor and your panel. And Connor, we have watched you grow up in this committee, and we want you to live. So my question for you, I think you're the best one, Connor. Are there any other times when you're in a healthcare facility that you might need access to your medical cannabis? Not just in an inpatient hospital setting, but any other setting?
Well, yes, I remember a couple years ago, around the time when I first started taking medical cannabis, I was required to do a test. I can't remember exactly what the test is called, but they used this stuff called barium, which they would pump it into. I had a feeding tube at the time, so they would put the barium. They would try to put the barium into my feeding tube so that they could see the way that my bowels move. They wanted to get an understanding of how my bowels move, because at the time they really didn't know too much. My stomach was. There was so much pressure in my stomach that they couldn't even get that barium through my feeding tube. It would not go in. It was like a dam in my stomach. So we talked to the nurses and the technicians that were there at that test. We told them, we disclosed with them that I use medical cannabis, and there was I think a little bit of hesitation, but they left the room. They said, you can have a couple drops of your tincture oil, and we'll see what happens. 5 minutes later, my stomach started moving. My stomach was not moving prior. I was not pumping that barium through my stomach. I was not able to do the test. If not for the fact that I did my oil right there, I would not have been able to do that test, and I would have had to come back, and the same thing would have happened. That was an outpatient test, yes. Thank you.
My pleasure. Thank you. Thank you. Any other questions, Delegate Kaiser?
Thank you, Madam Chair. Thank you, Delegate Johnson. Thank you for this bill. I'm a fan of this bill. I want to give you a chance to address the opposition letter from the Hospital Association and their concerns. I assume you've seen their letter? And to everyone else, they're concerned about their federal funding. So can you address any of that?
Well,
Thank
I mean,
you.
thank you, Delegate Kaiser, for the question. It's the same exact concern that we've heard on this bill and many other bills. Again, the feds have not gotten things in line, have not legalized it to be used medical. We're talking medical cannabis. Have not saw fit to get this straightened out where people who need their medical cannabis, their medicine, can use it in facilities, and they're afraid of the funding. Of course, we have other states that have enacted, California has enacted a law where you can have your medical cannabis in a hospital if you're terminally ill. Well, if you're going to give it to a terminally ill patient, why wouldn't you give it to a patient who is not terminally ill so they don't become terminal? So I think Pennsylvania has done something where just about like what we did with the schools, where they allow it in the hospital, but to be given by care providers, by designated care providers for the patient. So there are ways that other states see the need and are working it out to make it work for their citizens. So my hope and goal is to make sure Maryland legislators work it out to make sure we are taking care of our citizens. And hopefully the feds someday will sort this mess out. Like I said, it's going to get worse with our recreational cannabis without the feds getting on board. So we need help from the federal government, but until then, we need to figure out how to help our own citizens.
Delegate Riley.
Thank you, Madam Chair. Yeah, I had a question. So I'm hearing, so medical marijuana, it has different components and there's different, products for whatever, your condition is. So in your case, you're talking about the different components in yours. Was that developed with the medical marijuana industry, or was that your team of physicians that figured out the different things that has to be in your dose of medical marijuana to help treat your condition?
So it wasn't necessarily the physicians, because they don't have any part of that. It was fortunately people like Nurse Laura and other people around me who have kind of helped me steer myself in the direction of the kind of products that I need. But I have tested out all kinds of different things. As I mentioned, I cannot really use anything that doesn't have CBG, because that is the key component in giving me hunger and in making my bowels work. I didn't really have the time to explain it, but the way that my condition works is that I don't have any kind of bowel movements, period. As I mentioned, I have an ileostomy. I used to have a feeding tube, but prior to trying medical cannabis, I never felt hunger in my life. I was living in pain. I was living in nausea. And it certainly took a little while with experimenting with the medical cannabis, but there are a lot of different components. It's not just THC. It's not just cannabis. It is CBG. It is CBD. It is CBN. It is all kinds of different parts of the plant that do very different things for you. I'm sorry. I would also like to tack on one more thing. I don't mean to. CBG is not an intoxicating thing. THC is intoxicating. CBG is not. I would like to tack that on. Thank you.
Okay, Delegate Woods.
Be patient with me.
Absolutely.
Thank you so much, Connor, for your testimony. My question is this: is there any research that shows the detrimental impact that it has upon people who do not get the necessary support through cannabis? I lost my son in September of 2021. THC was one of the only things that helped him with a major seizure disorder. He has succumbed now to a seizure disorder because they would not provide him with medical cannabis. And so I'm wondering, is anybody doing the research to see how many people wind up adversely impacted because, and for my son, they literally said that he couldn't get the medical cannabis card because he did not have epileptic seizures, as if it makes a difference if you're having seizures and the seizure causes you to stop breathing. So my question is there any research being done to see the adverse impact of people who are being denied?
And if I may, one person can answer, only one person. Who's the best person? And Delegate, thank you for sharing your personal story. Very sorry about your loss, okay?
Yes, first I want to say I'm very sorry. So it's really sad the way the laws stand in our country right now. The focus for research, which we have struggled with research because of it being Schedule I, but anytime there is research, even anecdotal research, is usually more focused on the detrimental aspects of cannabis and cannabis use and addiction and any other thing except for the kind of research that you're asking for. But with the Connor Sheffield Foundation, we might be able to find and start doing some research. But it's a really good point, because we just focus on, even with the educational problems, the positions that are coming with the cannabis reform bill, which I know we're all going to hear lots more about and you already heard about, the focus even on education is a lot about the detrimental aspects and not the beneficial aspects of the medicine. And it's really important, and we need healthcare providers that are educated to help support people along that journey.
Okay. Thank you. Any other questions? Seeing none, I want to just thank you all for being here. Thank you for sharing your personal stories. We really appreciate it, and thank you for your advocacy. And
Thank you, Madam
Delegate, again, sorry. We have another panel that we're going to call now. Dina, Daryl Carrington, Renee Rissinger, Stephen Miller, Ashley Wine-Grimes. Will you get started?
I can start.
Yes, thank you.
Hi, my name is Dina Boble, and my journey with cannabis started in 2016. That was the year I was told I was going to be put on the liver transplant list, even though I never drank alcohol. My liver was bleeding, and my pain meds were killing me, so I had to make a change. I started researching what cannabis can do, and I used it to come off of 16 prescription medications, mostly opioids due to some other chronic medical issues I have. With cannabis, I stayed off the transplant list for almost 5 years, but my liver never fully healed itself. And in June of 2021, I had a liver transplant at Johns Hopkins Hospital, thanks to my daughter, who donated 65% of her liver. There were two things that were a huge concern for me. Number one was, how can I, as a mom, put my daughter through a major surgery that she doesn't need? And number two was, what are they going to do about my pain? I was terrified I was going to wake up and not only have to recover from a transplant, but also have to go through the process of opioid withdrawal again. If you aren't familiar with it, it's brutal. I woke up from surgery, and sure enough, I'm right back on the opioids. I had to take them for pain for a few days. I had no choice. I was barely awake. But once I was awake enough and able to think for myself, I refused them. I was literally cut open from side to side. My ribs were spread apart. My organs were removed. I had almost 100 staples across my belly, and let me tell you, it hurt. But anytime the doctor or nurse asked me about my pain level, I told them I was fine. I wasn't. I had to refuse the opioids. I was terrified of going down that road again. So I spent days in the hospital suffering in pain because they wouldn't allow me to bring my medical cannabis. I wasn't looking to get high. I just wanted to end my pain in a safe way. Just like you wouldn't give a recovering alcoholic a drink, why are you giving an opioid addict opioids when there's a much safer option? Luckily, I was able to fight through the craving for those opioids that I had to take, but not everyone can. And no one should be forced to suffer in pain because a hospital won't allow their patient's choice of medication, especially an opioid addict. We should not have to choose between the road of addiction or suffering and pain.
Thank you for coming today and for sharing your story with us. We
Thanks.
really appreciate it, okay? Next, please.
I'll go next. I'll keep this pretty short. My name is Stephen Miller. I was in a bad car accident in 1997. 4 years and 7 reconstructive surgeries later, I was hooked on opiates, Percocets and oxycodone. When Maryland started its cannabis program, I sought cannabis out to get off the opioids, and luckily for me, it was not a brutal battle, but it was very hard. If I had to go to the hospital today, I would not be able to use my medicine. I would be reliant on what they would give me, and that would be some form of an opiate for pain relief. And I don't want to go down that road again. Nobody should have to be denied their medication, especially something that's plant-based and that you have a cannabinoid receptor system built into your own body that if it wasn't there, you wouldn't be able to use the plant. So again, for me to go into the hospital right now is a scary kind of situation. And I do need a surgery that I've been putting off because of that, because I know that that's what they're going to give me is some form of an opioid for my pain, and I don't want to get addicted again. So if you guys can help us out with this bill, I'd really appreciate it as a patient. Thank you for your time.
Thank you for sharing your story today. We really appreciate it, okay? Thank you very much. Who's next?
Hi, I'm Ashley. Thank you for allowing me to share my perspectives related to cannabis, especially being inclusive of pediatric patients and the most vulnerable patients who cannot advocate on their own behalf. An example might be a dialysis patient who might have an opportunity to increase their own quality of life, who probably wouldn't be here because they're constantly in and out of the doctor's office and nearing the end of their own lives. Here are a few other things to consider. Some of them already kind of have come up. Cannabis is medicine, period. We brought up the endocannabinoid system. It's the largest neuroreceptor system in the body. We also make our own natural cannabinoids. THC is one that is mimicked within our bodies. We talked about CBG, THC, THCV is over 100 cannabinoids in the plant, which don't get overlooked, and we don't have enough research on. A lot of them probably do contribute to people like Connor. We've had a medical program since 2017. Our rec program is in the wings, and it's my fear that cannabis is going to lose its medical focus by focusing on profits, which we kind of covered too, with limited selections for patients who are in need of this in need of this bill. And this bill would actually enforce the medical components for patients inside and outside of the hospital, which also plays into the continuity of care and equal access to medical care. Patients who consume generally will avoid places who do not accept consumption. As we already have acknowledged, cannabis is medicine, and they should be able to consume in a location that is specifically intended to prioritize wellness. Patients who do not feel accepted will likely avoid access to medical care, thus decreasing their access to medical care. For example, Black and brown communities who distrust the medical system and avoided medical treatment during a global pandemic. It was catastrophic. Lastly, I remember an experience where a spinal cord patient was escorted off the premises due to cannabis tincture in his possession. He refused Marinol, which is an FDA-approved synthetic cannabinoid. He was a Black man, positive for HIV, recently suffered a traumatic injury and in need of rehabilitation and deemed to be a difficult patient, so he never received the rehabilitation he needed.
Thank you for sharing the story, okay? Who's next?
My name's Renee Reisinger. I'm a nurse practitioner in Maryland. Like Shanitha, I also graduated from the University of Maryland School of Pharmacy Master's Program to educate about medical cannabis. And as Ashley said, plant cannabis is medicine. Our federal government already said it was because our Department of Health and Human Services funded cannabis research in Israel decades ago. The research results were so impressive and so strong that in 2003, our Federal Health and Human Services put a patent on cannabidiol, or CBD. Cannabinoids have antioxidant properties. They help with autoimmune disorders, stroke, Alzheimer's, head trauma, Parkinson's disease, HIV, dementia, and many other diseases. So Ashley spoke about the endocannabinoid system. It is the master regulator of every other system in our body. And now that we know this, the stigma of cannabis as medicine needs to go away. We would never shame a diabetic for using insulin. Imagine a hospital system that would not allow a diabetic to utilize their insulin or bring it into the facility with them. Moving away from the science of plant cannabis, we enter the political realm. Maryland legislators created a high-quality medical cannabis program. It launched in December of 2017 via the Maryland Medical Cannabis Commission. It was orchestrated by the passage of the 2014 Natalie LaPrade medical cannabis legislation. Our Maryland legislators have already done the hard work and made an excellent program. Sadly, I think to most of us, it was unknown that our healthcare conglomerates kind of undermined the spirit of this legislation. The legislation noted above never forbid the use of medical cannabis in our healthcare facilities.
You can take a minute, a few seconds to finish your thought.
This has created immeasurable harm and suffering to patients because of the forbidding of our medical systems from letting patients utilize their medicine that clearly can help. And it was not the intent of the Maryland legislators in 2014. Per our beloved Maryland Congressman Elijah Cummings, we are better than this. We are so much better. Please consider passage of this bill to promote health and ease disease suffering of our population.
Thank you, and thank you for sharing your stories with us. Are there any questions for this panel? Any questions from our, thank you. There are no questions. Thank you so much for being here today, okay?
Thank you.
And
Thank you.
we appreciate it. Next, I have Daryl Carrington, Nikidra Cromwell, Rusty Carr, Matthew Meadows, and Warren Limley. And will you pull up some chairs, please? And will you be so kind and get started? Thank you. Who would like to get started? Go ahead, Mr. Carrington.
Great. Thank you, Madam Chair. For the record, my name is Darrell Carrington, here on behalf of Carrington and Associates, LLC. First of all, I'd like to thank the delegate for bringing this bill forward. When we originally did medical cannabis, we had always intended to treat all patients the same way, regardless if they were out of state or not, as some of the other folks have already said. If you're diabetic or have any other condition, we wouldn't treat you differently when you're in the state of Maryland. So this bill will make sure that that occurs. So I thank you for your time and ask for a favorable report.
Thank you. Who's next?
I guess I can go. My name is Warren Lemley. I am president, owner, and operator of Peak Relief, which is a medical cannabis dispensary in Rockville. I stand here today just speaking as an advocate for patients' rights and patients' health. I come from a unique perspective because I, being at a dispensary, have had the opportunity to speak to a lot of these patients and really kind of hear the stories, and very many, just like you've heard today, how life-changing it has been, and some of the other more subtle points that don't get discussed quite as often. Many people, when they go to medical cannabis, they do so trying to find a way to better treat their health, to have a more normal way of living. And in doing so, many times they actually move away from many of the pharmaceutical drugs that they used to use to treat the same conditions. So, one thing that I really want to emphasize is how important it is for when these patients might have an emergency situation, if they have to go and receive health care, continuity of their regimen and how they actually medicate is of the utmost importance. Medications can result in unexpected side effects, which can result in other forms of medication. And if we have something that is already useful in treating their conditions, then I don't see why we would have to move to any alternatives. One thing that is specifically close to me, I recently lost my mother-in-law due to cancer. We were discussing hospice. She never actually got the opportunity to go. But hospice is there for comfort. Our healthcare systems are there to care. And I think it is of the utmost importance that we make sure that all of our patients, all of our citizens in Maryland, have every tool available to them to treat them in the most effective and efficient way possible. And most importantly, when we have these very severe conditions, and God forbid someone ends up in hospice, that they should be able to receive that care that may have brought them comfort for years. Thank you very much, and I recommend a favorable on this bill today. Thank you very much.
Thank you for sharing your story. Sorry about your loss. Next, please.
Yes, my name is Matthew Meadows. I am a patient and advocate for medical cannabis, and as a person in long-term recovery, I find it of the utmost importance to have safe and legal access to my own choice of medicine, especially in a hospital setting. The scariest thing for someone who has struggled with opiates more than half their life is to have to worry about an accident or medical condition landing them in the hospital and being forced to take a prescribed medicine that has brought their life to complete and utter chaos. Because for some it may be a week of pain relief and grogginess, but for others it is an opening a door that may never be able to close again, a door that could cause them to fight for their sanity every waking minute. While a simple change, allowing us to access a plant that doesn't lead us back on a path of destruction, could mean life or death for your brother, your sister, sons, daughters, aunts, uncles, or someone you love. Because why are we going to the hospital in the first place? To heal, correct? Everyone heals differently. Many people have found healing in the universal uses of the cannabis plant. Wouldn't you rather see them happy and healthy than struggling to survive? I've watched too many people lose their lives in the opioid epidemic, and I myself have lost many years battling these drugs. And today I stand in front of you, a productive member of society, a peer recovery specialist through the state of Maryland, and a cannabis wellness advisor, and I owe my own recovery to the help of this plant. I ask you to please take this into consideration when making a decision on this bill.
Thank you for sharing your story with us today and being here, okay?
Thank you for allowing me.
My pleasure. Who's next?
Hello, my name is Nikedra Cromwell. I'm CEO and owner of Keedy Weedy. I'm also a patient advocate and a Maryland cannabis ambassador for the state, also a caregiver. But I was born with a neurological condition called Chiari malformation a few Years ago, they had me on 5 different medications, which was fentanyl, oxycodone, Oxycontin, Xanax bars, and all of that. I'm also a recovery coach. So I'm in favor of this bill because people should have that choice to be able to advocate for themselves and to help themselves. Because of this plant, it saved my life, and I'm here speaking to you guys today. Right now, I'm assisting my mom because she has passed both of her death dates going through chemo, and she's a cannabis patient for the state. Whenever she goes into the hospital, she's not able to medicate at all, and it sets us back tremendously. I have risked my life a lot, and I will continue for my mom because she's still here. But I support this bill, and I hope you guys support this bill because it is a miraculous plant, and it has medicinal, beneficial purposes that will help a lot of people also in recovery. Thank you.
Thank you for sharing your story with us.
Hello, my name is Rusty Carr. I'm a current medical patient and a caregiver also for my mother. She is a patient suffering from scoliosis, COPD, and a couple other things. She is a Kaiser Permanente. That's her healthcare provider. And Kaiser doesn't support cannabis at all. They won't recommend it, they won't sign it, they won't let it into the facilities. They don't consider it medical care. So my 91-year-old mom needs to go into the hospital. She's going to have the same problem that everybody else has already mentioned. So in terms of research, this is just one more case. My mother's situation is a little unique in that she was on a fentanyl patch, and her doctors told her that they were cutting off her prescription, not because of problems, but because of the opioid crisis. They tried non-opioid pain medication, everything they could find, nothing worked. They finally told my mom that there was no medical treatment available for her pain. She's now taking non-impairing doses of medical cannabis and still alive. The discussion we had before she started taking medical cannabis was life isn't worth living. Medical cannabis has kept my mom with me, and please, whatever you can do to let her get it when she needs it in the hospital, I appreciate it. Thank you very much.
Thank you for sharing your story, and I hope your mom recovers. Are there any questions for this panel? Delegate Riley.
Madam Chair, I guess this is probably best for Mr. Carrington. You might be able to answer this. So you had said that the original intent back when medical marijuana was passed here in the state of Maryland, that we had the intention of it being actually distributed in or given to our patients in a medical facility, hospitals, what have you. Are there any other states currently that have medical marijuana that have passed this and their hospitals are actually giving this to their patients? If not, would we be the first, which would be fine with me?
Thank you for the question, Delegate. I need to get back to you with an answer. I want to make sure that I'm accurate.
You cannot answer from the gallery, okay? Thank you. Thank you for getting the information to us. Send it to the whole committee, please.
Yes,
Thank you
Madam
very
Chair.
much. Are there any other questions? Seeing none, thank you for being with us and sharing your personal stories. Our last witness for this bill is an unfavorable, and it is Brian Frazee, the Maryland Hospital Association. You are a brave man.
Thank you, Madam Chair. Good afternoon, Madam Chair, members of the committee.
We were so serious. I just needed, seriously, go ahead. Tell us what you...
Thank you. Thank you. I appreciate that. Good afternoon, Madam Chair, members of the committee. My name is Brian Frazee, here on behalf of the Maryland Hospital Association, in very respectful opposition of this bill. I just want to start by first also adding my thanks to the advocates for sharing their stories. I also want to thank them for reaching out to us in the beginning of session to meet with us on this issue. We had a very productive meeting. I also, Delegate Woods, want to extend my condolences to your son as well on your loss. But again, we are here in very respectful opposition. And as you heard earlier, our opposition really is rooted in the federal rules that govern the use of cannabis. Cannabis is still a Schedule I drug at the federal level. And Medicare conditions of participation are very clear that our hospitals must follow federal law. And so that really puts us in a sticky situation with an issue like this. And I want to be very clear that that is the root of our opposition. Our opposition is not rooted in the health or the benefits of medical cannabis. It's in the in where the feds are on this issue. So with that, again, very respectfully, we urge an unfavorable report.
Are there any questions? Delegate Kaiser.
Thank you, Madam Chair. Thank you, Mr. Frazee. So I heard more than one person testify that they were addicts when they went to the hospital, and they wanted the medical cannabis, but instead were being offered a narcotic instead. And so I guess my overall question is, how does that fit into the hospital's philosophy? And on that related note, when we were in the hospital, when my wife was giving birth to our beautiful daughter, she asked for cough medicine and was told, that's not on your schedule, but we can give you oxycodone. And so I went down to the pharmacy and bought her cough medicine. So I'd like to really address the question of how is it that narcotics are allowed and not this, given that, especially for the addicts, I'm not including my wife in that, I'm including the people who told their stories, and thank you all for sharing your stories of how is that appropriate?
Sure. Thank you, Delegate Kaiser. Certainly understand your point. I'm going to have to get back to you on the exact answer on the narcotics piece. And I'm not a clinician, certainly, so I can't answer in terms of the issue with the cough medicine and kind of that particular situation, but happy to follow up with you directly on that.
Delegate Hill.
Thank you, Madam Chair, and thank you. I'm just wondering about the possibility of a don't ask, don't tell. So I'm sure the hospitals have times when patients are caught smoking or eating or using. What's the general policy of the facilities if someone who's a patient is partaking of recreational, medical, or other cannabis?
Sure. Thank you, Delegate Hill. So the policies that the hospitals have that govern all of that are consistent with federal and state laws, regulations, CMS conditions of participation. All of those have to be consistent from top to bottom. And so they have teams that are very specifically looking at those policies to make sure that they're following, you know, what the law and what the regulations say and what our regulators hold us to.
Sure.
Are you saying that if a patient is found to, if they walk by and there's smoke, that they're kicked out of the hospital? Or they told, please put that away, that's not allowed? I mean, specifically, what are the policies in the hospitals when they're dealing with people who are smoking illegal substances?
Sure. I don't know the recourse, you know, when those situations do arise. I know they're not kicked out of the hospital, you know, for those situations. But again, happy to follow up with you on more detail on that.
Delegate Chisholm, followed by Delegate Lewis.
Thank you, Madam Chair, and mark this down in the historical books that Delegate Hill took my question, but but we do know that in many hospice settings that they are running on this very same, and I don't want you to incriminate yourself, they're running often on this very same type of model where they're taking medical cannabis to ease their pain. If we have to wait on the feds, is there any possibility that it could be implemented without anybody looking? And because we're talking about lives. I mean, I know Connor personally now, and so we're talking about life and death, and I know we talk about that a lot in here, and I'm not asking that you tell your hospitals to do this, but the conversation's going to have to be held at some point. And I know you've had conversations with Connor's family and the other advocates, but have you had this conversation with the 60 hospitals and their administrators running the hospitals?
Yes. Yeah. Thank you, Delegate Chisholm. So I would say two things to that in response. One is, you know, hospice, they do have they're a separate entity, a separate industry, so they kind of have their own laws and regulations they have to follow. We have talked to our hospitals, and to your point, certainly understand where you're coming from on that, but we do have to follow the rules and regulations that are governed by, these different entities at the hospital level. So again, that's where our opposition is rooted in. I will say we're always happy to have conversations about ways to move issues forward, but on this one in particular, it's tough given where the feds are.
Delegate Lewis.
Thank you, Madam Chair.
You're welcome.
Thank you, Mr. Frazee. This is an emotional subject, so now I'm going to have to ask for a little grace while I get my thoughts back together. A couple years ago, 2019 to be precise, we passed legislation requiring hospitals to disclose to patients when they might experience a high fee for seeing their provider in an outpatient setting. It was it's one of my first bills that I worked on, but it's the Facility Fee Right to Know Act. And it was challenging. It took us 2 years to figure out how to help hospital systems share information about potential medical charges. And I remember learning about the difference between policies that are imposed in hospitals and in buildings owned by hospital systems that are considered outpatient. There's different rules. And I was just wondering, just recalling those negotiations and the creativity and commitment everyone brought to the table, wondering if a potential solution to the on-site hospital prohibition of personal use of Schedule I drugs. If a space could be designated non-hospital where hospital staff who've taken that prohibition pledge wouldn't go, where no hospital activities would take place, but where patients, whether they're inpatients or outpatients, might, when they need to, self-dose with their medical cannabis product. Just remembering how great the Hospital Association was in just figuring out the facility fee. And may I mention also the goodwill that the Hospital Association brought to discussions on medical debt. Those are really tough. Those require the hospitals to do something, to take action, adjust, adapt. Asking the Hospital Association to consider just creating a space where y'all don't have to actually do anything, where patients could self-dose. Is that a conversation that could be had that would protect hospitals from repercussions of federal enforcement and at the same time keep Marylanders alive?
Thank you, Delegate Lewis. I'll say to that, we are happy to have any conversation around this or any issue, as you know. Always happy to come to the table to try to find creative solutions. That's certainly an interesting idea. It's the first time that I've heard of that concept, and I know we, of course, would need to talk to the Health Services Cost Review Commission and our legal counsel and kind of see if a model like that could work. But again, we are committed to talking and coming to the table and having those conversations. Absolutely.
Thank you. Seeing no other questions, thank you very much for being with us.
Thank you.
This actually concludes the bill hearing on House Bill 1135. I know that we have some of the same witnesses for 1172, but I'm going to take a little break from that one for a minute. And I'm going to call two very fast bills. I'm going to start first with Delegate Bartlett. We're going to call House Bill 863, Delegate Bartlett, Public Health Chief Medical Examiner Corrections to Autopsy Findings and Conclusions.
Thank you, Madam Chair.
Do you want me to hold a minute and call another one that has 3 witnesses if you're waiting or not? Oh,
No,
there
we're
she
ready.
is.
We're ready,
Okay.
yes.
Thank you. And Delegate Henson, I'm going to call you after this bill. All right? Thank you. Delegate Bartlett, you can get started on House Bill 863.
Thank you, Madam Chair. Members of the Health and Government Operations Committee, it's good to see you. I am here to introduce House Bill 863, Sandy Bartlett, for the record. House Bill 863, if it is enacted, would extend the time in which a person in interest may appeal a medical examiner's findings and conclusions resulting from an autopsy. You may remember, some of you may remember, I was here about 2 years ago, and we amended the section to allow family members to appeal the cause and manner of death. I'm here today to talk to you about extending the time frame in which to make that appeal. And that is to go from 60 days to 180 days, because a family in grief should be afforded time and grace. I have talked with the Chief Medical Examiner of the state of Maryland, Dr. John Stash, via Zoom, and followed up with emails, several emails, and he has responded to each and every one. I appreciate that. He reported to me that the bill does not appear to have any significant operational or fiscal impact on the office, and the fiscal and policy note confirms that statement. I am here, obviously, to answer any questions, but this is not a complicated bill. I have spoken with the advocates you see here before you today, and we have reached reached an agreement on the 180 days. They will speak for themselves with respect to what they would prefer, and maybe we will ultimately get to. But right now, we're looking at 180 days. Thank you so much for your time.
And thank you very much for your testimony. Who would like to be next, please? Yes, please.
Good afternoon, everyone, and thank you, Delegate Bartlett. I'm Reverend Marguerite Morris, and I speak on behalf of the Anne Arundel County Police Coalition, which represents 20-plus organizations around the county. I also speak as an impacted person. We support House Bill 863. I previously come before many of you testifying on matters related to the death of my daughter, Catherine Morris, who died in 2012. We challenged the handling of her death investigation for a whole decade. It was at my request that Delegate Bartlett brought you Part 1, HB 934, which became law, successfully closing a decades-old loophole. The state tried to use that loophole against me to deny me a hearing that I persevered in and won, and wound up arguing as a pro se litigant in a 5-day hearing where I brought over 14 witnesses, 100 exhibits. The state lost, the state appealed, and according to Maryland Matters, in 18 years, there were 22 appeals, and mine was the only one that was successful. Finally, in 2022, in that victory that resulted in a judge issuing a 58-page opinion that resulted in a change from suicide to undetermined, which I'm sure most of you would say meant unsolved, right? Because her death certificate now says they don't know where or when, nor the manner of her death. In 2022, I went back to the police to ask as a good show of face to list her death as unsolved. In 2023, Anne Arundel County Police Chief Amal Awad literally put her knee on my neck, and a massive abuse of power said no. This case was administratively closed in 2012. In my opinion, this was retaliation for the voice that you now hear and will continue to hear. This is an example of abuse. Families facing matters like this could in no way file a complaint when they just buried their loved one, and if they have something wrong, prove the allegations of misconduct, abuse of power, failure to properly investigate, etc., and prove it in 60 days. I've asked, and I've spoken several times, who was on first when they thought that you could do all of this in 60 days. In closing, I'd like to say that please remember that no matter what we accomplish legally, by an example, there is a force known as the FOP that undermines all and seeks to oppose the many baby steps of which you're giving us. But we are determined to move the needle forward. We will not give up nor go away. So please move HB 863 forward so that it will help other impacted families across the state of Maryland. Thank you and God bless you.
Thank you, and sorry about your loss, and thank you for your advocacy. Thank you. Who's next?
Good afternoon, Chair Melnick and members of the committee. For the record, my name is Yanetta Emanuel, Public Policy Director with the ACLU of Maryland, here in support of HB 863. Maryland families who have lost their loved ones to violence while in the state's custody continue to be hamstrung by the current 60-day limit to request correction. The current limit is not enough time for grieving family members to obtain autopsy report, understand it, and assess whether they have concerns that rise to the level of requiring review. It is often the case that only after a medical doctor or specialist reviews the information that a family learns of the possible significance or insignificance of the info and what can reveal about their loved one's true cause of death. Additionally, in a number of cases, family members are denied access or are significantly delayed to accessing not only medical reports, but also police reports, witness statements, body camera, or other footage that may capture their loved one's last moments. Therefore, it can take months after the incident before a family has critical materials, medical counsel, to make the decision to request a correction and finding. Our office knows of at least 2 people with chronic medical conditions that have died within the state prison facilities within the past 3 years. In both cases, family members waited roughly a year for written medical examiner reports, despite the Office of Chief Medical Examiner verbally providing bits of medical findings by phone during that period. One family waited 15 months for a copy. The other family is still waiting now, and is now a month away from the 1-year anniversary of their loved one's death. In Maryland, where long-standing failures to accurately conclude manners of death in the OCME have led to a statewide audit, the very least that we can do is give these grieving families enough time to obtain all the information that they need in order to assert their rights. We thank Delegate Bartlett for bringing this important bill forward, and most importantly, hearing the concerns of her community, and urge a favorable report on HB 863. Thank you.
Thank you, and thank you for your testimony today. Are there any witnesses for this sponsor and her panel? Excuse me, any questions? Seeing none, thank you so much. And I want to just take a minute to say thank you very much for sharing your story. You know, and the committee will certainly take it under consideration. Thank you so much.
Thank you.
You have a question? I did not see. 1 second. Go ahead.
You may have mentioned you said instead of 180 days, it should be extended to 1 year. Are you fine with that?
Yeah, no, we can't do 1 year because I've spoken with the medical examiner, and Ms. Yanette Emanuel is representing ACLU, and we have talked and negotiated, and we are at 180 days. So we are fine with 180 days. She had to go to another bill hearing. I told her I would say those words. She approved it. We are fine with 180 days, and she also just testified to the same. Thank you.
Are there any other questions for this panel? All right, seeing none, thank you very much. This actually concludes the bill hearing on House Bill 863. We're going to go back now to 1172. Actually, House Bill 1172, medical cannabis visiting qualifying patients. And that is Delegate Collison. She's not here today, but her intern will make the presentation.
Good afternoon, Madam Chair and honorable members of the committee. For the record, my name is Matias Cacheira, and yes, I am the intern for Delegate Collison in District 19. Thank you for this opportunity to present House Bill 1172, Medical Cannabis Visiting Qualifying Patients. This is a very simple bill. It would allow an out-of-state resident with an out-of-state medical cannabis card to purchase medical cannabis in Maryland. Many out-of-state patients travel to Maryland for treatment at one of Maryland's world-class hospitals. They should be able to legally access cannabis while treating in Maryland. Why would an out-of-state patient need a Maryland medical cannabis card? First, an out-of-state patient would be prohibited from buying cannabis in Maryland adult use market. Second, the patient may be a juvenile, and again, the patient would not have access under the adult use program. And finally, even if an out-of-state patient could buy in the Maryland adult use market, the medical program allows for the sale of higher THC product than the adult use program. We have been working with the Maryland Cannabis Commission on amendments. The amendments would provide for the following. An out-of-state resident with a valid out-of-state cannabis card could acquire a Maryland cannabis card through the Maryland Cannabis Commission. Maryland would accept the qualifying condition recognized by the patient's home state. The commission would issue a card, and the patient would be subject to the same rules and regulations as a Maryland patient. The bill's effective date would be January 1st, 2024, to ensure there is adequate supply after the start of adult use sales in Maryland. Thank you for your consideration, and I respectfully request a favorable report. And I, with that, turn that over to my panel.
You tell Delegate Collison you did quite well.
Thank you.
You're welcome. Who would like to be next?
Go ahead.
Hello again. Thank you, Madam Chair and esteemed members of the committee. Once again, my name is Warren Lemley. I'm the president and owner and operator of Peak Relief, a Maryland-owned independent operated dispensary in Rockville, Maryland. I strongly support House Bill 1172. When I was first awarded my license for District 17, it was for where I grew up. You would have a hard time finding someone, quote unquote, more local than me. My high school, which I graduated, is within 5 miles of my location. I took it very seriously for the opportunity to serve my community and provide them the best quality medical cannabis and the best service possible. I stand here today as an advocate for the patient's rights because I also took it as my responsibility to utilize this chance to actually sit here and actually try to get some better laws and some more availability within our state. Now, I know that Maryland has quite a reputation. We have quite illustrious healthcare systems, Johns Hopkins, Walter Reed, NIH, and it's unfortunate that we have patients that travel from all over the country to receive the specialized care. And these patients don't have the ability to utilize the medical cannabis that they have become to rely upon. Obviously, there's a lot of similarities with this bill and the bill I spoke of earlier, just from a different purpose. You know, being in my position as a medical cannabis dispensary, I've had to have many times where I've had to turn away patients and actually send them away to Washington, D.C., where they do allow reciprocity. There's been veterans who've come seeking treatment for Walter Reed. There's been patients that have been seeking treatment from Johns Hopkins and others. I think one of the most important aspects is that pediatric patients are not going to have access to the adult use industry. Many times when I've brought up reciprocity and the ability to utilize medical cannabis in our state, people have asked, well, when their adult use is here, then why is that necessary? And as we have mentioned, there's going to be higher dose products, things that are most important for those with cancer and severe forms of illnesses, many of which that we've heard on today. So with this and many other reasons, I do ask that we have a favorable report on this bill. Thank you very much for your time.
Thank you for being here. Next.
Thank you, Madam Chair, members of the committee. My name is William Kress. I'm here today on behalf of Peak Relief. I appreciate the delegate's office and the intern explaining the bill. I thought they did an excellent job. So we've been working with the commission to get some amendments that they feel comfortable with, and there are really a couple issues that they wanted us to address. First of all, they wanted to make sure that the out-of-state resident was actually part of, in the system, and they were able to track what they were buying at the cannabis dispensaries. Secondly, they wanted to ensure that there was adequate supply, and so we've made the new effective date January 1, 2024. With those two amendments, I believe the commission is going to be supportive or at least neutral in the bill. In the past, there were some issues about whether or not past legislation, whether they could actually track the sales. So if you're an out-of-state resident, you would come in, you would produce your card, your ID. The commission then would issue a Maryland cannabis card for you. They would be tracked. They would be under the same rules and regulations that apply to all Maryland citizens with a cannabis card. And it's a pretty simple bill. Thank you.
I have, before we go on to questions, two more people on this panel, Nurse Laura Barrett and Tricia Sheffield.
I'm going to stick up here for questions.
You can get started.
Hi, I'll just keep this short. Basically, I support this bill because I've been in that position with Connor, being in another state, worrying, what if he loses the medication? What if he runs out? Like, what we do? So I'm empathetic on our visitors, they could be in the same situation. So I definitely think that we definitely need to try to do something for cannabis patients from out of state. That's all.
Thank you.
Thank you.
Next.
Hi, Nurse Laura again. Thank you again for having us. It's very ironic that our bills are on the same day because they are so similar and related. And I just want to say, I shared earlier that one of the things that I do is I counsel patients, not giving them the recommendation to use the medical cannabis card in Maryland, but I help them figure out how to use the medicine. Well, many of you might know that a lot of Marylanders winter in Florida, and so Florida also has medical cannabis, but we don't have reciprocity here or there. And quite a few of my patients struggle greatly when they travel because I am a law-abiding, rule-following citizen, even though I'm a medical cannabis nurse. And I'm like, you can't bring your medicine to Florida. You can't bring your medicine back to... It's very tricky. And so I really hope that you will support not just for those, winter, summer flopping people that need access in both states, but for the children, as you heard, and just for people that come to our amazing medical system. I'm so grateful to have been previously a part of Hopkins, but LifeBridge Health, University of Maryland, we have these amazing places here in Maryland that people come from all over the country to utilize, and it's so sad when they come here and they're once again stuck with opioids and other medications, benzodiazepines, that might not be as helpful to them. So I hope that you support this bill. Thank you.
Thank you. Before I open it up for questions, you say you have some amendments. Have they been reviewed and approved by the commission?
I submitted them to the commission today via email. We just got them this morning, so I'm waiting to hear back.
All right.
But they are based directly on our conversations and meetings with the commission.
All right, thank you. There are some questions, so I'm going to start on my left. Delegate Pruski from Economic Matters.
Thank you, Madam Chairwoman, and thank you for the bill. You did a great job presenting. I think, Mr. Kress, you could probably, because you're dealing with the amendments, on page 2, it talks about photographic identification or a valid driver's license. I know that when you go to a store, you have to show sometimes a government-issued license. When you talk to the commission, were they okay with this generic language? Again, we're not trying to be too specific, but I was just curious that if this is no issue.
So that was not an issue they raised, and it may be addressed in regulations. Frankly, I'm not certain.
Thank you.
Thank you. Delegate White.
Thank you, Madam Chair, and thank you all for your testimony. It was mentioned that there isn't this level of reciprocity in other states. I'm wondering, have other states adopted this legislation where reciprocity may exist? And if so, could you share if this bill is, if anything, similar or modeled after those other states?
Sure. Certainly. There actually are quite a few states that do offer reciprocity. I do believe the number right now is between, I think, about 12 and 15 other states that currently do it. A couple that come to mind is I know that Nevada has it. As I mentioned, Washington, D.C. actually offers reciprocity. So any medical patient from around the country can actually go to Washington, D.C. Sadly, they have a much smaller program there with fewer options for medical patients. But once again, there are quite a few, like I said, about a fifth, I guess even more than a fifth of the country actually does allow reciprocity.
I have next Delegate Kipke, followed by Delegate Kaiser.
Thank you, Madam Chairman. To whomever is best at answering this, one thing I was going to ask the commission, who hasn't signed up to testify, I don't believe. Why isn't the card from another state good enough? It sounds like they want to issue a new, card, and so that might create a delay. So I don't know what the rules are about traveling with medical marijuana throughout the country, but I don't think you can. So, like, if you're going to just stay here for the weekend, I would think you'd want to, get it quickly if you have a medical condition.
Thank you, Delegate. I appreciate the question. So this was part of the discussion with the commission. They want to be able to track folks in their system. Initially, they raised concerns about out-of-state patients possibly getting more cannabis than Maryland patients because they're not tracking the amount that's being sold. So that's a legitimate issue, and we recognize that, and we think the amendments address that. We think we're comfortable with the bill the way it is because the cards are issued relatively fast now. There's not a big backlog. But we did discuss a possibility of an additional amendment, perhaps indicating that the commission would have to do it in an expedited manner. And I know that's something the sponsor is considering. Thank you.
Delegate Kaiser. You're welcome.
Thank you, Madam Chair.
It'll come up. Just go ahead and talk. Yeah.
Okay, thank you. And related to Delegate Kipke's question, but not exactly the same, Mr. Kress, in terms of the cards, in dealing and talking with the commissioners, have they said how long it might take to turn around the Maryland card for a visitor who's here?
I don't think any promises were made. I think the current time status, the time frame is pretty quick.
Yeah, it certainly fluctuates depending on how many people happen to be applying at that time. Here recently, I'd say within the last 6 months or so, maybe even a year, they have been being issued much more rapidly. One of the suggestions I had made that he alluded to was we currently expedite the caregiver cards that we give to people when they are trying to be serve patients. So one of the things that I am hopeful for is that we might be able to expedite them in the same process. Obviously, I don't know the inner workings of the MMCC. I'm on the other side of that scenario, but I would hope that we might be able to have the applications for out-of-state patients be basically funneled into the same category that we see caregivers within our own state.
If I could follow up. Thank you, Madam Chair. I heard you say the words much more rapidly. I have no idea if we're talking about 3 weeks, 3 days, or 3 hours. So can you give me some frame of reference?
Yeah, certainly. I've been hearing that they've been awarded within days.
Any other questions for this panel? Seeing none, thank you very much
Thank you.
for
Thank you.
being here. We really appreciate it. We have one last witness on this bill, and that is Darrell Carrington. I want to thank my colleagues from Economic Matters for being patient.
All right. Good afternoon, Madam Chair. For the record again, my name is Darrell Carrington, here on behalf of Carrington Associates, LLC, and our cannabis clients. It's been a very long day. I believe everything has been said. We have not seen the amendments, although they do not sound controversial to us. And so we would like the opportunity to review the amendments, but we believe will be favorable. Thank you very much.
Thank you. Are there any questions for this witness? Seeing none, thank you for being with us today.
Thank you, Madam Chair.
And this actually concludes the bill hearing on House Bill 1172. I want to thank my colleagues from Economic Matters for being with us. Thank you for your patience. We are now going to call House Bill 725, Delegate Henson. And thank you for your patience, those of you that are waiting for the last two bills. We really appreciate it. And you may get started. Do you have a panel? You actually do. You have Lorraine Arakat. Can you come up, please? We have Tammy, Eric, Reba, and Diane.
Thank you, Madam Chair. May I begin?
Yes, please.
For the record, I'm Shanika Henson on behalf of House Bill 725. House Bill 725 is a wage pass-through bill for our nursing home caregivers. This morning on the floor, we got an opportunity to acknowledge several caregivers that joined us this morning. So for them, we know that it's been a very long day, but as I get to know them, I understand that very long days are something that they have become accustomed to. The way that the bill works is that it would provide a rate increase for our nursing home providers, but it would also require that a portion of that rate increase be tied back to worker wages. So it would pass that through to make sure that our workers were getting the advancement in their wages that they need. I want to thank the rock stars of this bill, and that's why I've positioned myself on the periphery, because I truly have been just a participant in this. Everyone you see at this table and some of the folks who you see signed up in opposition who were favorable with amendments in the Senate, but I won't call anyone out, they have worked very hard to try to come to a place of compromise where we can support our caregivers. And so that's why I'm so proud to be a sponsor of this bill. The reason why this is so important to me and so many people, the folks who are in our nursing homes taking care of all of our loved ones, they earn very low wages. In 2021, the average annual wage for them was just $34,000 a year. Among certified nursing assistants, over 90% of them are women, and over 50% of them are people of color. Additionally, 1 in 5 certified nursing assistants are on public assistance, and 31% of them lack affordable housing, and it disincentivizes people from being a part of the profession. The American Health Association, which represents nursing homes across the country, released a survey that said 98% are experiencing difficulty hiring staff, and 76% of their facilities are in the current financial situations where they lack the funding to offer competitive wages. This bill would be a support to them as well, because it would give them that funding that they could use for competitive wages. And the last data point that I'll provide is that a study from Leading Age at the University of Massachusetts, Boston, said that raising the pay of direct care workers by just 15% would yield impressive returns, including concrete benefits for all of the stakeholders involved. So for those reasons, I'm very proud to sponsor this bill. I also understand that as soon as I take this seat, this bill becomes the work product of the committee. So I would ask the committee to build on the work that's been done by these stakeholders in the interim for many months to see if there's some resolution that we can provide for those who are giving long-term care. Thank you very much, Madam Chair.
Thank you, I appreciate it. Who would like to be next?
Go. Good afternoon, members of the committee. My name is Lorraine Arikat. I'm the Senior Policy Analyst with 1199 SEIU. We are co-founding members of the Caring Across Maryland Coalition, a broad coalition of care workers, patients, loved ones, and advocates impacted by our broken care system. We urge a favorable report on HB 725, which is about investing in our care workforce. The workforce crisis is interconnected with the economic stability of the sector, and 98% of nursing homes are struggling to hire new staff, and 76% say that funding is the reason why they're unable to offer competitive wages to hire new staff. This bill is a sustainable way to address the staffing crisis and to protect quality of care. Medicaid is the primary funder of our nursing homes, and labor is the most expensive cost. This bill will increase Medicaid reimbursement rates and ensure a fair portion goes directly towards worker wages and benefits. We have been intentional about working with groups like HRAM and have introduced agreeable amendments together, and will continue to work with the Department of Health in the interim to ensure the necessary shifts to ensure compliance. The investment in our long-term care infrastructure is also important to Maryland's unique healthcare system. Maryland is the only state which operates under what is called the total cost of care model, which is overseen by the Health Services Cost Review Commission. While the HSCRC does not have authority over long-term care providers, our Maryland model demands that care settings outside of our hospitals provide high-quality care. In fact, our system's success hinges on the ability of all providers across the spectrum to ensure that we reduce unnecessary hospitalizations. This legislation ensures taxpayer dollars supports nursing homes to have safe, adequate, and dignified care by care workers who are justly paid and well supported. Patients and care workers deserve better, and that's why I urge you all to issue a favorable report on HB 725. Thank you.
Thank you, and your timing was perfect. Ms. Tammy Bresnahan, go ahead.
Good afternoon, members of the committee and members of the Health and Government Operations Committee. I'm Tammy Bresnahan. I'm the Senior Director of Advocacy for ARP Maryland. On behalf of our almost 900,000 members, we would like to thank you for the opportunity to speak in support of House Bill 725. And we also want to thank Delegate Henson for introducing this very important legislation. You have my total testimony, so I will just be brief. ARP believes that living wages and salaries should be commensurate with comparable salaries in the state and with the time, skill, and effort required to render high-quality services and supports. Medicaid reimbursement rates should be rebased and updated regularly to consider relevant economic and financial information, including provider cost. State governments should require pass-throughs, like this bill, or other mechanisms to increase compensation for direct care workers. We are very committed to making sure that Maryland has the best long-term services and support in the country. Right now, we rank about 13th, and we can do better. We can do better than New Jersey, who ranks 4th. We can do better than Minnesota, who ranks number 1. So with that, I'd like to ask you for a favorable report on House Bill 725. Thank you.
Thank you very much. Eric Fulchimuro, go ahead.
Madam Chair, members of the committee, Eric Colchmero for the record, Alzheimer's Association, here in support of House Bill 725. Much has been said by my colleagues. What hasn't been said is it's a bummer that this bill is necessary. It's a bummer that workers aren't getting paid enough and have to work multiple jobs. It is a bummer that the industry, who received over $100 million in COVID-related relief funds, isn't already doing it. But they're not, and this bill is necessary. It's necessary for the over 40% of residents of nursing homes who have Alzheimer's and other forms of dementia. It is a manageable fiscal note, and it is a choice. And it is a choice to choose this bill that helps both providers in allowing for a rate increase, where some of it has to go to the workers. And it's a bill that helps their workforce. And these providers are better because their workforce are getting incentivized to stay, to have higher wages, to be part of the solution in providing effective care to people who need it. So we ask for a favorable report. We thank you for the time.
Thank you very much. Go ahead. Is this Reba McKinney?
No, I'm Diana Jarek on behalf of the Public Justice Center.
I didn't have you on the sponsor panel. Are you?
Oh, I might be too early. I can switch somebody else out. I'm so sorry.
Do we have a Reba McKinney?
Yes.
I have you on the list, Diana, just not on the panel.
Good afternoon, everyone. So to Madam Chair and the members of the committee, my name is Reba McKinney, and I'm a geriatric nursing assistant in the long-term care facility in Maryland. I'm also a member of 1199 SEIU. I urge a favorable report for HB 075 funding for healthcare workers. I work in long-term care because I love what I do and that I get to help people. Some of my residents don't have family members who can visit them, so I become more like patients' family. It also brings me so much joy to be able to put a smile on their faces, even if it's something simple like ironing a shirt or helping them eat a bowl of cereal. The only downside of working in long-term care is our wages are far too low. It's hard to survive on low wages. With the cost of living, I'm having trouble providing food for my family, and I have to gamble every month how late I can pay a bill just so that I can keep food on our table. I can't always afford my medications, and that negatively impacts my health. I want to be able to afford a good quality of life for my family. My son is 16 and his prom is coming up. He's so excited to go to the prom, but I can't afford everything that he will need, so I'm considering taking on a part-time job. While this will help ease the cost of living and burden a little bit, it would mean that I will be spending less time with my family, and especially my grandchildren. I'll be 43 years old this year, and I'm worried about how I will be able to retire with dignity because I'm not able to save any money for myself after doing the best to provide for many families. I caught COVID twice, and I had to miss out on celebrating Christmas with my family so that they wouldn't get sick, and Christmas is also my granddaughter's birthday. I enjoy singing because I have long-term COVID side effects that hurts my ability to sing. I have sacrificed so much to provide for loved ones during the pandemic, and I earned enough, and I don't earn enough to make a livable living. So please vote yes on this bill. And as much as, I'm sorry, that's time.
Go ahead and finish your thought.
You know, putting my life on the line and putting my health at risk to take care of other families. I just urge y'all pass this vote so I can afford to take care of mine.
Thank you, and thank you for the work that you do. To the members, this is the final witness on the sponsor panel, so we'll go ahead and open it up for questions. Delegate Kerr.
Thank you, Madam Chair. Eric, you mentioned $100 million in COVID relief money. Do you happen to know if any of that went to employee bonuses or any of the initiatives you're talking about today?
I don't know. It might be a good question for the representatives from the industry. We have a worker here. I don't know if she could speak to whether she really received any bonuses.
We received COVID pay literally for only 4 weeks. And that was only if you came in contact with a COVID patient. So while every other department in doing everything else, unless you came in direct contact, you did not receive anything.
Thank you. And just a reminder that we normally do one question, one answer, but we allowed it because we wanted to hear from the provider perspective. Are there any more questions from the members? I have one question for the bill sponsor. Have you been speaking with Tricia Roddy from the Medicaid, from Maryland Medicaid?
Yeah, I'm just going to answer on behalf of Delegate Henson that we do have a meeting scheduled with Tricia Roddy.
Okay, great. Thank you very much. All right, that's this panel. Oh, I'm sorry, Delegate Hill.
All right, thank you, Madam Chair, and thank you. Delegate Hinson, there's two things. Number one, is the 10% an arbitrary number, or is it based on something? So we went from 4% increase to a 10%, so I was wondering about that. And then I also was hoping you could explain, or someone could explain, exactly what the cost report is supposed to do. I'm not clear on what that information that's supposed to give us.
Would you mind if whoever's best to answer?
Yes. For the last couple years, skilled nursing facilities and long-term care settings have been getting a 4% reimbursement rate. Last year, they got a bonus, which equaled to be about 12%. And this year, we were asking for 10%, but we actually worked, like I said in my testimony, we worked and collaborated with Health Facilities Association Maryland on amendments. So those amendments lowered the rate increase to 8% starting in fiscal year 2025 for the next 3 years. 70% of that will go towards direct and indirect care worker wages and benefits. And that is something that we are trying to make sure that we're meeting nursing facilities demands to meet their full capacity, but also have some accountability of how much will that go towards workers. The cost reports are really important for ensuring that we as a public can see how skilled nursing facilities are spending that money. So the cost reports is a form and a tool for compliance.
Just looking to see if there are any other lights. It really is hard to see them up here. All right, thank you very much to the sponsor panel. We have two more witnesses favorable. We have Diana Jarrett and Rhonda White. Come on up and you can go ahead and get started.
Good afternoon. Hello, Madam Chair and members of the committee. My name is Rhonda White, and I am a certified medicine aide in a long-term care facility in Maryland and a delegate in 1199 SEIU. I urge a favorable report for HGO 75 to increase our wages. As a healthcare worker, we make sacrifices on the front lines of the COVID-19 pandemic to care for your loved ones. Some of us survived, others lost their lives, or we're forced to leave healthcare due to low wages. For those of us still working, we are dealing with a short staffing crisis. This was a problem before the pandemic, but even worse now. In my facility, we have 1 GNA to 20 patients. When we don't have enough workers, patients just can't get the proper care. We always strive to provide high-quality health care, but we can't be everywhere at once. Management paying us low wages keeps our facilities short-staffed because they are failing to recruit and retain workers. When we don't have enough workers, our mental and physical health also suffers. We are stuck in a cycle of not having enough workers. So many workers burn out and quit. Then the short staffing cycle continues. Raising our wages will stop this short staffing crisis. For the sake of workers and patients, please vote yes on this bill. Thank you.
Thank you very much. You can go ahead and get started.
Thank you. Good afternoon. My name is Diana Jarek. I'm an attorney with the Public Justice Center. Specifically, I work for the Workplace Justice Project, which works to expand and enforce the rights of low-wage workers across the state of Maryland. Much has been said by my former panelists, so I will be quite brief. I do want to speak to the labor shortage that Ms. Rhonda just alluded to. Currently, the state of Maryland employs about 55,000 direct care workers. Within the next decade, research projects that we will need to fill an additional 129,000 direct care worker roles in order to care for the state's aging population. Put simply, we need to attract people to want to work as direct care workers like Ms. Rhonda and Ms. Reba. In order to attract and retain these workers, though, we need to pay them adequate wages that they can live off of, wages that are commensurate with the work that they do for all of the people living in nursing facilities and that they work for in their home settings. The most direct way in order to retain and let's try this one more time. To attract and retain our direct care workforce is by increasing the reimbursement rate for this work and ensuring that the money goes directly to care workers' wages. And that's exactly what this bill does. And so for these reasons and for all of the reasons so eloquently put by my former panelists, the PJC strongly supports this bill and urges a favorable report. Thank you.
Thank you. Are there any questions for these two witnesses? Thank you, and thank you for sharing your story. I was in the kitchen and I listened to the story while I make myself a cup of tea. After doing something. Anyway, thank you for being with us. We really appreciate it.
Thank you.
My pleasure. Next, we have Deborah Brocado, Donna Kaufman, and Aaron Greenfield. You can get started.
Good evening, Madam Chair, members of the committee. For the record, Dana Kaufman on behalf of Lifespan Network. You have my written testimony and my bullet points regarding the specific provisions in this bill, and I'm happy to answer any questions that came up during the previous panelists, but I just want to use my minutes to make this one point. First of all, I 100% agree that the work in nursing homes are hard and that those workers deserve to be making more money, without a doubt. And it does contribute to our nursing crisis as far as hiring, because we can't compete with the big box stores. You can go to Amazon and make more money. We are well aware of that. But the issue has to start from the top, and that is with Medicaid. Unfortunately, the state has always been a bad payer. It's not just with nursing homes, but it's across Medicaid. It is with medical adult day. It is with residential service agencies. It's across the board. This committee has dedicated itself to trying to pass studies that have been done. They were done in 2018 on the cost of care and the reimbursement levels, and it was found that the two don't mix. So budget language went in to require a five-year plan to how to mesh those together. That wasn't done. I think it was 2 or 3 years ago we tried again in one of the RSA bills to have them update the study. It wasn't done. So we're always back in this catch-22 about trying to figure out how we can elevate wages, but at the same time, the Medicaid program has to do that as well and increase funding. I will say that we do blueprints for education and for justice, but we have never had a blueprint or a plan for healthcare, and that time is right now. Thank you.
Are there any questions for these witnesses? I have to say, we do have two, not blueprints, but we have the Behavioral Health Bill and the Public Health Commission as well this year for healthcare.
Right.
As well. Seeing no other questions, thank you for your testimony. Appreciate, oh, you have to tell me your
I don't-
decision.
Madam Chair, I don't
Sorry.
have, Madam Chair, I don't have to tell you
You know what, women,
anything.
we speak for men, don't
Yeah,
we? Just
listen.
kidding, go ahead.
As a man with 3 daughters, an ex-wife, and a girlfriend, and two female dogs, I couldn't agree more. Madam Chair, members of the committee, Aaron Greenfield here on behalf of
We
Leading
needed
Age
to break the
Maryland.
ice, it's okay, go ahead.
I'm here on behalf of Leading Age Maryland in opposition to House Bill 725, and would agree with Ms. Kaufman with respect to this being really tough work, and the workforce shortages certainly don't help the industry. Leading Age Maryland is a community of more than 140 not-for-profit organizations serving residents and clients through a myriad of facilities. We support increasing wages for direct care workers and other staff. Most of our members and many of the nursing home providers across the state have already adjusted to providing a minimum wage of at least $15 an hour or more. However, as Ms. Kaufman noted, reimbursement mechanisms must be aligned to ensure that providers are also able to meet rising costs in other areas of operation. Unfortunately, this bill ties the hands of Medicaid providers. We appreciate significant Medicaid reimbursement rate increases. We appreciate them. They're urgently needed, in part to support the rising costs of operations, which include increased prices of products, testing, PPE, and staffing. Medicaid providers have experienced chronic underfunding, as you've heard, coupled with the rising costs. And just unfortunately, unlike other businesses, we can't pass those costs on to our consumers, to our patients. We have had some discussions with the proponents with a series of amendments, which we're still reviewing and going back and forth, but at the present, for those reasons, we respectfully request an unfavorable report.
Are there any witnesses, I'm sorry, any questions? I think I need to just, I'm glad we're almost done. It's been a long day today. Anyway, Delegate Johnson, go ahead.
Thank you, Madam Chair, and thank you, panel. Mr. Greenfield, can you tell us, do you know if any of your clients got any of the $100 million federal funding and if any of that went to wages?
Yeah, I'm fairly sure that the members got some of the money, the way it was dispersed, but I don't know. It's a question I have. When Delegate Kerr asked the question earlier, I believe, I texted my client to find out if there is any information, and I'll follow back up with you.
Committee?
Yes.
Thank you. Thank you.
My pleasure. Are there any questions for these witnesses? Now, that was proper, right? And there are none. So thank you so much. All right, next we have Deborah Brocato. Not here? Okay. We do have 2 virtual witnesses. Will you be so kind and allow them in? Thank you. Good afternoon. Will you be so kind and get started? Thank you.
Hear myself called on.
Oh, yes.
Flag.
Yes. We can.
Thank you, Madam Chair. My name is Christopher Meyer. I'm a research analyst at the Maryland Center on Economic Policy. We strongly support House Bill 725 because it would strengthen Maryland's workforce and ensure that we're investing our shared resources in good jobs. I think most of what I have to say on this bill, the committee members already know and other witnesses have already said. Direct care workers are a vital part of our social infrastructure. There's a severe and growing labor shortage, and that shortage is primarily due to deeply inadequate wages and benefits. House Bill would attack that in 2 ways, by first increasing Medicaid rates to make sure that providers can afford to pay better wages, and then making sure that those rate increases actually get through to workers. The bill also helps ensure proper stewardship of our shared resources through the cost analysis, generating more information that policymakers can use to make effective decisions. Then, as the committee also knows, a major portion of any increased investments under House Bill 725 would be funded by the federal government. That also means an infusion of cash into the state. And low-wage workers will amplify this economic benefit by spending their increased income at local businesses. I think that wraps it up. Thank you. I'm asking for a favorable report.
Well, thank you for being with us today. Are there any questions for this witness? Thank you so much for, your testimony. We have one last witness, and it's Nicole Henry, and I know she was there. Let's give her a minute. Thank you for your patience, everyone. Ms. Henry, will you be so kind and unmute yourself? You can get
Hello.
started. Yes. Hi, how are you?
I'm fine. Hi, Mr. Chairman and the rest of the committee. I was calling to speak my piece on the bill that we are fighting for today. It is the HB 725 bill. I'd like to speak on how low wages impacts me personally in my life. I have two daughters, and I'm 16, sorry, and a lot of overtime shifts. Being out of night, don't to do things.
You're going in and out. Are you able to stay in one place? It's coming in and out. Yeah, just try it from there. Go ahead. Yes, we can. Yes, we can. You can go ahead.
I'm trying to figure out what's going on.
No, we can hear you now.
Going in and out.
We can hear you now. Can you continue?
Hello?
Okay.
Hello?
Yes, we can hear you.
Okay. So I have a 16-year-old and a 9-year-old, and I want to explain how low wages impacts me and my family. I work many doubles, a lot of overtime and night shifts because I cannot sustain my family financially. And when I say sustain my family, I mean, with regular pay, I cannot sustain my rent, my car payment, my car insurance, my health insurance. I pay $500 for one medication a month. That's an injection because I have lupus. Also, I have my 16-year-old babysits my 9-year-old, causing her to miss a lot of her high school activities that she has to take part of. It also causes me to have to rely on other things, other means that takes me away from my family, maybe cooking dinners to sell dinners. Also, what's going on with my phone? Also, when I say that we, like I was saying, I pay $500 a month in health insurance, and I can't provide for myself, but I'm taking care of other people's families. It's kind of hard to fathom the idea that I'm taking care of other people's brothers, sisters, cousins, and loved ones, and I can't financially take care of my own health. How does short-term staffing impact me and my patients? Example.
Don't worry about
Hello?
that. You can continue. Go ahead.
Okay. So here's an example. One night, about 2 weeks ago, I worked on a unit with 60 residents, and it was only myself and another GNA. We had to care for the residents, protect the residents, make sure they were safe, clean, dry, nothing that would cause a bed sore. And we didn't have enough. So it hurts the residents. They're not getting the proper care, the one-on-one care that you can give your residents if you have, say, maybe 10, 15 residents, because we don't have enough staff. Also, it's physically damaging to us as healthcare workers. I mean, to think that we're spending most of our life at work, taking care of someone's sister, brother, cousin, uncle, and we don't have enough staff. We don't have enough staff to care for them like we would our own family members. It's very frustrating. I'm begging that you take consideration into this bill, as it means a lot to us as healthcare workers. Even mentally, we are dealing with a lot, and to think that we're putting a lot of mental anguish on ourselves to take care of people. Like, I enjoy being a healthcare worker. I enjoy communicating and taking care of people. I take pride in how my residents look. And to think that I take pride in how my residents look and my family, my personal family is suffering is a big deal to me.
Well, thank you for sharing your story. The committee really appreciates it, and you certainly gave us a clear picture of what you do at work and what you're going through, okay? I hope you have a blessed day.
Thank you.
Thank you. Oh, wait, are there any questions for her? There are no questions. Thank you so much.
Thank you.
My pleasure. And this actually, let me just check since I've been making a few mistakes. I think this is actually the last witness that we have. So it concludes the testimony on House Bill 725. Delegate Henson, I want to thank you for being patient and your witnesses for being with us today. You have a wonderful day. Next, we have Delegate Smith, who has patiently waited. She's the last bill of the day, and she only has 3 witnesses. You see how they were waiting for you and how happy they are to see you? So we are calling now House Bill 876. Delegate Smith, you have Kathy Costa and Melanie Gordon-Newell. And you can get started. And thank you for being flexible with us today.
I guess, okay, it said do not touch. I just wanted to make sure it was on.
Oh, it's on.
Thank you, Madam Chair. In her absence, Madam Vice Chair, and to my distinguished colleagues who are a member of HGO Committee. For the record, I'm Delegate Stephanie Smith. I'm here to present for your consideration House Bill 876, and it's concerning the Maternal Mortality Review Program that was first set up by this body in the year 2000. And just as a refresher for those who may not be aware, the purpose of this program was to identify maternal death cases, review medical records, and other relevant data to determine, why are we losing, these birthing persons, determine preventability of that death, and develop recommendations for the prevention of these deaths, and then to also ultimately disseminate these findings across the community of stakeholders so that we can reduce these adverse outcomes we have regarding maternal health. As many of you know, there are obviously differences between different racial and ethnic groups in terms of outcomes related to maternal mortality. But as a whole, our nation is far behind many other developed nations in terms of our maternal health outcomes. And I'm proud that Maryland has taken some leadership as far back as 2000 to try to get to the bottom of it. The purpose of this bill is to really just change a really small word so that those local maternal health review committees that were enabled through this legislation, and they have to be convened by a city or county health officer, should your jurisdiction have one of these maternal mortality review teams, this bill will enable them to get the data and the information that they need in a more timely manner as they're reviewing various maternal death cases. Most specifically, right now, when they are requesting, information like prenatal care information and other records pertaining to a death, there's not an immediacy to sometimes the receipt of that information. And as you can understand, as you're reviewing these cases, you're trying to get a hold of all the data and necessary information to conclude why did this happen? And if there can be an indefinite time frame to receive that information, it really slows down the Maternal Mortality Review Committee's efforts. So this bill just requires those requests to be complied with immediately. So that's really the only thing this bill does. It's a simple bill, your last simple bill of the day. And so with that, I know that we have some stakeholders who want to weigh in and support, but I just want to say thank you for all of the deliberate action you've taken today on a host of matters. I respect what you do greatly because there's a lot that you deal with. So thank you for bearing with me as your last bill of the day. And I do hope for a favorable report for House Bill 876. Thank you so much.
Thank you. Who's next?
Good evening, Madam Chair, members of the committee. My name is Nina Themelis. I'm the Interim Director of Government Relations for the Mayor's Office, here to testify on behalf of the Baltimore City Administration in support of House Bill 876. So Delegate Smith, I want to thank her for introducing this bill on behalf of the administration and for providing that very extensive overview of the bill, so I don't have to speak very much more about it. So this expanded access will allow for the the maternal teams to identify systems gaps, factors contributing to maternal deaths, recommending strategies to prevent future maternal deaths, and another of other issues. But I'm going to turn it over to Kathy Costa, who is the Infant Mortality and Child Fatality Review Director for the Baltimore City Health Department, who can speak a little bit more specifically about the importance of this legislation. Thank you.
Madam Chair, members of the committee, my name is Kathy Costa. I'm at the Baltimore City Health Department in the Bureau of Maternal and Child Health, and I oversee, in addition to fetal, infant, and child mortality review, I oversee the local maternal mortality review team. We have been experiencing challenges ever since we started the team in 2021, the local version of the team, in accessing medical information about the maternal deaths. The legislation that allowed local health departments to convene local teams specified that rather than accessing medical records on our own, that we get summary information from the state. Instead, from the state maternal mortality review team, and that information comes to us. It's often delayed. We've had to cancel meetings. We've had to delay reviews by months while we're waiting for this information. And so this bill would enable us to access the medical records directly, and we would be provided immediate access to those medical records upon request of our health officer. This is what we really need in order to be able to do adequate reviews of the maternal deaths in Baltimore City. We do understand some may believe it's duplicative for both the state and local teams to access the same records. We're talking about a very small number of cases, though, between 2 and 12 a year, so this is not a difficult burden for medical providers. So we respectfully ask for a favorable report on House Bill 876.
Thank you. Before I open it up for questions, I have one of the sponsor. Did you see the letter from MECI?
Yes, I did.
Okay, have you been working with them?
I know that you've been talking with.
Because they write in their letter that the deletion of the data use agreement and substitution of the word immediate raise a number of questions, including but not limited to what does immediate mean in terms of time frame. For example, does it mean that the data is to be provided prior to the review by the state maternal mortality review, which could result in duplicate reviews and conflicted findings? Further, the state MMR often has its own challenges in receiving requested records and data, therefore raising the question of whether immediate is realistic or achievable. House Bill 876 also requires the provision of prenatal data, even though the data is not relevant or requested, received by the state in all maternal death cases.
May I respond? I will say that my teams request records all of the time. The fetal infant mortality review and child fatality review statutes both specify that we have immediate access to those records. So this language is just duplicating what's already in the statute for those teams. And in practice, it's never immediate. There's always some back and forth requesting. It may take 7 days, sometimes with some hospitals where, it takes a month or so. The important thing is that the legislation specifies that they are to honor those requests of medical records, because otherwise, without that, they wouldn't do it because of patient privacy concerns. So we recognize that immediate is not always in actuality immediate. With regard to the conflictive findings, I will say we would never be reviewing a record review a death prior to the state reviewing a death. They're the ones that notify us about the death after their review. So there's never a situation where we'd be reviewing in advance. And as far as conflicting findings, it's only the state team that provides findings to the CDC on maternal deaths. The local teams do not make those same findings. And we use the results for preventability purposes only. We do not make the official findings.
May I ask, Delegate, will you be so kind and meet with Pam Casemeyer, please?
Absolutely.
And work on the language?
Absolutely. Happy
Thank
to
you.
do so.
We do have Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Smith, for bringing the bill. Good to see you here, and thanks to your panel. I get the impression that the maternal mortality review team has a different style of responding than like the fetal mortality review teams, another team that you mentioned. Are you saying that legislation is needed to get the review team to do what it was supposed to already do in law? And how bad is it? Like, what do you see as the source of the problem? Whoever's best to respond.
So when we passed legislation in 2019 to enable local maternal mortality review teams to exist. And at that time, we passed a compromise. We had this immediate access to medical records language in that original bill. But the MedChi at that time wanted us, rather than accessing medical records ourselves, they were concerned about confidentiality. We compromised and we said we would get summary information from the state maternal mortality review team instead of getting the medical records themselves. And then as we could have predicted at that time, we've had difficulty actually getting the summary information from them, and that's what has caused review meetings to be delayed or canceled while we're trying to obtain the summary information. The other thing that happens when you don't have the actual records themselves and you just have the summary information is that people invariably have questions on the team, and we're not able to answer them because we didn't actually abstract the medical records ourselves. And sometimes they're basic questions that just weren't addressed in the summary the state provided, and so we're stuck. So this is why we wanted to seek, just as we did in the original bill, access to the medical records themselves.
Madam Chair?
My pleasure. So you're only allowed here?
Okay, no problem.
One person, so I apologize. I
No
have
worries.
to be consistent with the rules, but Delegate Hill can ask you what you were thinking. Delegate Hill, go ahead.
I'm just very curious about what Delegate Smith was thinking.
Well, thank you.
Could you answer that
Delegate.
question?
Yeah, I was really just wanted to add that it's great that we've created a system to constitute all of this expertise, but if they can't maximize the value of those convenings, it's kind of like, what's the point? You know what I mean? So I think they really want to solve the problem, and they feel a bit hindered in maximizing, all their skills and talents because they have incomplete data.
And this is the last time, because the other day.
I'm sorry.
Someone else did it, okay, and I said not to do that, because otherwise we're here back and forward, okay? So I have to be consistent, but we had a long day. So, any other questions? Seeing none, I want to thank you for being patient and for being here, okay? And I hope you have a blessed day. Please work with them.
Yes,
and
ma'am.
let us know, okay?
Thank you, Madam Chair.
My pleasure. This actually concludes the bill hearing on House Bill 876 for today. So we're done with all the bill hearings for today. I want to thank you for your patience because it was a long day, a lot of witnesses. Tomorrow, I don't know what tomorrow looks like, but you can probably expect the same now until crossover. So just make sure that you eat, take a break. I want to ask you something. Do you guys want to break? Do you want to break in the afternoon? Actually, we're done, so you can turn it off. I want to know if you want to break, or do you want to continue? I feel like I push you. Like I sit here and I try to get it done so that you're not here 8, 9 o'clock, 10 o'clock at night. And I feel like if we have a break, it's hard to get everyone back together. But this is a collective decision. What do people think? Yes, Delegate Hill, then Johnson.
Well, we all can take our breaks when we need them. You're the one that doesn't get to take a break.
Yeah. As long as the